by emailing ccc.ps@boston.gov. And of course, thank you to all of the panelists for being here today. For the sake of time, I'm going to simply turn it over to the sponsor for opening remarks, and then we're going to go straight to the panelists to allow them to speak, and then open it up for questions from all colleagues. Councilor Sabi-George, you have the floor.
Thank you very much, Madam Chair, and thank you for bringing us together this morning on what I think is a really important topic and a really important piece of work that we've been doing as a city, and something that I've been committed to since joining the council in 2016, and did some tremendous, what I think is tremendous early work with then Councilor Presley, now Congresswoman Presley, regarding an increase in the funding that we had for our BEST team, so mobile crisis clinicians that are a critical part of Boston's ability to respond adequately to public and mental health emergencies across our city. The brief bit of history, and I think Jenna will do some of this in her remarks in her presentation to the group, but we had just a few, I think 2 at one point, grant-funded positions when it came to BEST clinicians doing the work in our city. It was some federal funds to work with Boston Police at the time to do some of that work. When I joined the council, I was doing some work with then Councilor Presley around the importance of having these clinicians as a part of that work, and we were able to advocate for and get some additional funds to hire 2 more clinicians, and then as a part of our operating budget, increase the number of clinicians that were doing that work and create some security around the work so they weren't reliant on those grants. We've now moved to this point where we have $2 million invested in additional up to 15 clinicians, which would right size, I think, this force of clinicians to best respond to the needs of our residents across the city. I just want to thank the mayor for that investment. It is a tremendous investment, something that we've been working towards over the last few years and the last few years that I've been on the council. So I think that this effort, this work will have a huge impact on the quality of life for our residents, especially those that don't need a police response, but a mental health response to the crisis that they're in the midst of. And I just want to congratulate and thank Jenna and Peter Messina and the rest of their team and Tasha from BMC on the work that they've done to date. I've had a front row seat to the efforts and the thoughtfulness that they've put in to thinking about how these funds will be spent, how we will best allocate and resource our assets, our city's assets, both in terms of funding, but then also in personnel and the people that are going to do this work on behalf of the residents here in the city of Boston. So again, I'm excited to see the presentation in full today and to share that work and to share my work with colleagues on the council, and excited to get to work with these clinicians for the benefit of our residents across the city of Boston. So thank you, Madam Chair, and thank you to the colleagues who are here today to hear about this work and to ask about this work and be more informed about this work and maybe inform this work going forward. Thank you, Madam Chair.
Thank you, Councilor Sabi-George. I also want to acknowledge we've been joined by Councilor Julia Mejia, so thank you for being here. And I just want to echo the thanks to folks from the administration, BMC as well, for being here this morning. We have a lot of great panelists. I'm going to jump right in and turn it over to you. Sergeant Messina or Jenna, are you going to lead the presentation?
That'll be me.
Okay. So we'll turn it right over to you to get right into it. And then after all the panelists speak, we'll then go to colleague questions. If they want to add any opening remarks, they can do so then. So Jenna, it's all you, and I think Kerry, working behind the scenes, is going to help us show your presentation. So I think you just have to share your screen.
Okay, great. I'm going to go ahead and do that now. Let's see if
Thank you.
Okay. Everybody see that okay? Everybody hear me okay? Okay, great. So I'm Jenna Savage. I'm the Deputy Director of Research and Development at the Boston Police Department. I'm going to be doing this presentation with Tasha Ferguson and Lauren Snyder from BEST. I want to first say thank you to Madam Chair for hosting this hearing, and of course to Councilor Sabi-George for sponsoring it. It's been a pleasure working with you on this work over the years. So let's get right to it. So just to give a sense of the scope of the issue, in 2019, there were about 10,000 mental health calls for service in the city of Boston. The code EDP is for emotionally disturbed person, and about 7,000 of them were EDP2, which means that there was either a weapon present or some sense of violence or threat of violence to self or others. And to those types of calls that are coded as EDP2s, both police and EMS respond to those calls. There are also EDP3 calls, and there were about 2,700 of those where just EMS responds. Those are lower level. There's no sense of violence, no threat, no risks or concerns. But we should also keep in mind that these 10,000 are a severe undercount because these are only those calls that are coded specifically as mental health related. So keep in mind that there are so many other types of calls that end up having mental health involved, including domestics, investigate persons, family trouble, overdoses. I mean, so many different calls involve mental health. So 10,000 is severely undercounting just the extent of the scope of the issue. But just to give a sense of how many calls we get in the city of Boston. And thank you to EMS for their data on that. So traditionally, when police respond to these calls, in the absence of having corresponding clinicians, they really have about 3 different options. And this is what the Boston Police were generally doing up until this partnership started. First, they could send the person with EMS and have them transported to an emergency department, which can be absolutely the proper response, but there are also cases where that's not necessarily the best response. It's also expensive, and it doesn't guarantee the person's going to get the services they need. The person can also just be told to kind of stay where they are or move along, and that does not connect them to services in any way, shape, or form. Or when there's criminal behavior involved, they can be arrested, which again might be the proper response, but then involves the person with mental health issues in the criminal justice system, which can have its own repercussions. And since 2010, formally the BPD has been partnering with the Boston Medical Center's Boston Emergency Services team. They're our mental health partner, and that has really changed the way BPD does business with respect to mental health response. And with that, I'm going to turn it over to Tasha Ferguson.
Great, thank you, Jenna.
Yep.
So what I'm going to describe first, and thank you, Jenna, for setting that up. Also, thank you certainly to City Council for inviting us here today, is our general BEST team, our overall team, which does respond to the community with and without police. And so I think that's an important context to set. So we are the emergency services provider that covers the greater Boston area, and that is all of Suffolk County, as well as Brookline, Cambridge, and Somerville. There are emergency services programs that cover every city and town in Massachusetts, and for our area and responding to Boston, Boston Medical Center is the lead agency. We also work with 2 community partners, Bay Cove Human Services and North Suffolk Mental Health Association, to deliver services into the community. So the core of what BEST is that it's a mobile psychiatric response to the community, and this is performed by master's level clinicians. It is available 24/7 to the residents in the areas that we serve. And I'll just point now and just illustrate that at the bottom of each of these slides is our 800 number. This is a toll-free 1-800 number. It is answered 24/7 by master's level clinicians. And so other psychiatric providers, the police, or members of the community themselves are invited and welcome to call this number whenever they're in need of urgent behavioral health services. Our goal, our mission, and the mission of all emergency services programs is to respond in a mobile capacity into the community, to the site of where someone's experiencing their crisis, to help resolve that crisis, and hopefully in responding to the community to also reduce overcrowding at emergency departments, which I think we're all well aware is a significant issue in the Commonwealth right now. Our clinicians who work for BEST are really experts in emergency psychiatric evaluation and also into linkages to treatment. And so these can be traditional behavioral health resources. They can also be other kinds of basic resources and needs that we know that many of the individuals struggling with behavioral health in the community experience alongside their behavioral health issues. Let me pause here to say also, by behavioral health, that does extend as well to people with substance use disorders or concerns around substance use. Again, as noted previously, you can access BEST services at any time of day by calling our 800 number, which is listed here again. And one enhancement that we've made recently, particularly in light of the COVID-19 health crisis, is to begin offering emergency care by telehealth. There's a very easy process that our call center will walk a consumer through if they call us and this is an appropriate response. And essentially we're able to offer them a secure telehealth link where they just click on it from any kind of smart device, and they're connected to a clinician who can perform really the same evaluation that they would in a face-to-face capacity. Additional resources that are part of the BEST system, and this is really in light of the fact that there is a lot of risk in these situations when we're responding to people who have acute needs in the community, is that we have access, again, 24/7 to BMC credentialed psychiatrists who can offer consultation to our clinicians who are in the field, as well as a very robust system of team supervisors, including at the agency level for our community partners, as well as Boston Medical Center, to help provide support to the clinicians in the field, offer psychiatric consultation, and really make sure that everybody's needs are being met. We also run through emergency services to community crisis stabilization units, which are treatment settings. They're 24-hour treatment settings. We have 2 units located in Boston. One is on the Boston Medical Center campus in the Solomon Carter Fuller building, and then we have an additional unit in the Longwood Medical area at 20 Vining Street, which is the Mass Mental building. Additionally, we have 2 partner emergency departments that we work with. That's Boston Medical Center, as you might imagine, and then also Mass General Hospital. And at those 2 locations, the physicians and social workers who are there have access to our web-based electronic medical records so that they have the full benefit of all of the mental health information, substance use information we have collected on all of the clients that we have seen since 2003. So it's a very robust resource to really understand someone's previous struggles and how we might best assist them right now. Okay. So, and I think this is really the crux of what we're meeting about today, how BEST helps BPD officers. And again, let me offer for context here. This is both in terms of our co-response project and partnership that we've had with BPD for many years now. It's also for officers who may not be currently partnered with a co-responder. They equally have access to the rest of our BEST resources. And I think that's important because even with additional clinicians, and we're very grateful for the opportunity to expand our team, there are still always going to be far fewer clinicians riding with officers than officers out in the community, providing for the public. So even if an officer is not paired with a clinician, they can still receive these benefits, and we're very happy to offer them. So one is that whenever there's an individual with behavioral health issues, again, traditional mental health concerns or substance use disorder in the community, we're able to assist the officer in determining the correct response. So for individuals who might have very high needs, be sort of dangerous to themselves or others, we are able, through consultation with our psychiatrist, to either issue a Section 12 or assist police in appropriately issuing a Section 12 to have the individual brought to an emergency department for further evaluation. That's an important tool to really make sure that if somebody is brought to an emergency department, that they receive the type of evaluation that really meets their needs. And without the Section 12 document, there's less of a guarantee that that will happen. We're also able, again, either on site because it's a co-responder clinician or a mobile team clinician may be able to meet an officer at a scene where they're assisting an individual in the community. We can offer intervention right on site. And this often looks like de-escalating the situation, having a just brief therapeutic opportunity for the person to express their concerns, and making recommendations to them about what kind of behavioral health services may be beneficial to assist them with whatever brought them to police attention. Additionally, we're able in the community to make plans to follow up with the individual that came to police attention, and that can be done later the same day, or it can be done in the following days to check in, ensure that the crisis really has resolved, and hopefully avoid them coming back to the attention of first responders, either police or EMS. And so that's an important goal for us. Aside from those services that we offer in the community, we are also able to go into police stations to assist with an individual who might be being held in a holding cell at that time and is experiencing some crisis. And so again, that looks like de-escalating the situation or assisting to de-escalate the situation, providing a safety assessment on whether or not the person should continue to be held in the holding cell, or if that situation is not appropriate, we would assist in issuing a Section 12 to transport the person, again, to an emergency department where their needs can be met. And we are responsible to connect with the designated forensic professional who then would facilitate admission to a state forensic facility if that's appropriate. So that's one of our other responsibilities when somebody is actively under arrest. In addition to those, we will also provide follow-up or intervention for individuals who may be repeat 911 callers and there are many unfortunate cases where individuals, due to symptoms of their mental illness, or sometimes some of our frail elderly consumers that we meet in the community, have a lot of fears, which result in them calling 911 repeatedly. There's not a public safety concern, but certainly they do need support. And our hope would be to support them so that we can reduce their calls to 911 and reduce that expenditure of resources. We also can intervene with families who maybe themselves have been the victim of a traumatic event, or perhaps have witnessed a traumatic event in the community, to provide some brief counseling and intervention for that purpose. Certainly many of the calls that we assist BPD with involve families that are experiencing a crisis, an interpersonal crisis, a domestic crisis. And so we provide some support and referral to services for individuals in those circumstances. I mentioned briefly already that some of the individuals we interact with may be older adults, but equally for juveniles or youth in the community, both in the community and at schools. We're able to provide a response to them when they've been brought to the attention of police. Finally, and I think this is very important, whenever able, we assist in diverting situations that do not require an EMS ride to the emergency department. This is important, as we mentioned earlier, for reducing ED overcrowding. When the emergency department is not necessary for someone to receive services. And also certainly it results in significant cost savings. There's an estimate here of about $4,000 per diversion. We think it may even be higher than that, but sort of minimally, we're looking at saving a lot of monetary resources by doing that. And then, this slide, I think, illustrates, and again, in the context of the fact that we are both responding to the community initially without an officer, as well as in a co-response capacity. There are many ways in which Boston Police assist my team currently. And so one increases safety and allows the clinicians to really go to environments that without the presence of Boston Police, we may not feel are appropriate to send a clinician into. And let me highlight here, our clinicians are mental health experts, but they are not public safety experts. And so if a situation requires some physical intervention or the assurance of physical safety, we often will call upon Boston Police. Even if we didn't initially arrive on scene with them, we may be calling 911 to have someone respond to assist us with that situation. For clinicians who are co-responding with police, it's a significantly faster response time. All emergency services programs have a 1 hour response time, and that's part of our contract and sort of the metrics that we try to reach. But 1 hour can feel like a very long time when somebody's in crisis. And so our clinicians who are riding around in cars with officers are able to arrive on scene much, much faster than that and provide a more immediate response, which again may help to prevent a further escalation of the situation or need for arrival at an emergency department. It allows our clinicians also, when we partner with BPD, to respond to people in crisis that we might not otherwise be able to access. I think we're all aware that there are still stigma in our community about behavioral health, and so a family and individual may not identify themselves as having those concerns, and so would not choose to call a behavioral health crisis line, but do choose to seek assistance through 911. Those are people that it's hard for us to reach, but certainly who still need our assistance. And so when we're able to respond with Boston Police, we can intervene in those situations, even when the person may not have identified it initially on their own behalf as a behavioral health issue. It also allows us to even just introduce the idea of emergency services to individuals, so that if the reason they did not call BEST in the first place was because they were not aware of our services, and despite efforts, that certainly continues to be the case on some occasions, we can now provide them that information so that moving forward, they could choose to call us if they are comfortable with that, and if they do find themselves in need of behavioral health services. So that's an important part of word of mouth and really reaching into the community that I think it's very difficult for us to do otherwise. And again, I mentioned this previously, but really to highlight, police officers, in Massachusetts are able to issue Section 12s. What we have heard previously from officers is that they may not feel totally comfortable doing so until they really have that knowledge and expertise that I think we provide either directly on scene or through trainings, which you're going to hear about in a little bit, to help them make sure that they are fulfilling that responsibility safely, appropriately, ethically, and so we're happy to, provide them assistance to, again, sign their own Section 12s or to issue it, in the case that our psychiatrist may be a better source of that, in the moment, depending on the factors. So there are other ways I think that BPD assists us as well, but these are sort of the highlights of where we really see their benefit.
Tasha. Just to give a bit of history, as Councilor Sabi George mentioned, we've been going back with BEST for quite a while now. The 1-800 number has been around, I'm not even sure how long. And initially, the BPD partnership with BEST was with a focus on homelessness with our former street outreach team, which many of you probably remember Al Zalaway. He was wonderful and is now happily retired. But in 2010, I should give a shout out to Andrea Hall from BEST. This is Tasha's predecessor, who came to us and with the idea of expanding this and making this partnership more formal. And at that time, we applied for a federal grant through BJA and also a state Department of Mental Health grant as well. And the BJA grant, the federal grant, allowed us to develop an e-learning video, which is an electronic, virtual way for officers to learn. And it was made mandatory for all officers to really learn about who is BEST, when's the right time to call them, what's the best way to contact them. So it really just started to increase awareness about BEST's existence and how that can be helpful and be a helpful tool to officers. And at that point, I think most people did not really know about them. And then through our state DMH grant, we were able to launch this co-response program. And that was through, again, DMH funds. And it was piloted in District B2, which is Roxbury. And that was, let's see. Okay, so more about the co-response program. So as Tasha mentioned, clinicians, when they're co-responding or just through 24/7 hotline, they're available citywide. But beginning in 2010, we started this co-response program using grant funds, first through the Department of Mental Health, and then over the years, we also got federal BJA funds as well. But basically, we are able to put clinicians directly in district stations where they can ride along with officers. And again, we piloted it in Area B. We've also used these funds to support a part-time peer specialist. And again, we had a BJA funded clinician for a while in Area C, which is South Boston and Dorchester, but currently those funds have expired. And that really goes to the point of how difficult it is to rely on grant funding for these positions, because the funds come and go, and it makes it really hard to have that turnover and to establish those relationships. Because as you probably can imagine, it was not easy getting officers to trust these clinicians and having them ride with them. It took a long time. So I should also give a shout out to Ben Linsky, who is now an officer himself, but he really did that groundwork of kind of working through the barriers of officer trust and getting to know people, and really made it possible for this program to take root. But beginning in 2017, and here I have to thank again Councilor Sabi George and then Councilor Presley, took an interest in this and really brought it to the forefront and enabled us to get City Council operating budget funds to hire more clinicians. And we've had about $234,000 in our operating budget since then, since 2017, so for the last 3 fiscal years. So in addition to our one DMH funded clinician who still covers Area B, which is Roxbury and Mattapan, we now have, because of City Council funds, a full-time clinician covering Area A, a part-time clinician in Area E, and a clinician who covers Area D4, but that person also is the clinical supervisor. And if you want to know Area A, E, and D4 mean, they are written on the slide. And I'm also happy to share this slide with anyone who wants it, this presentation. But our District D4 clinician / supervisor is Lauren Snyder, and I think she is next on how this program really works on the ground.
Thank you, Jenna. I wanted to walk through for everybody how this really plays out in real time to support officers in the field on these challenging calls. Clinicians are usually paired up with the officer at the discretion of the duty supervisor at roll call. Sometimes that happens because an officer makes themselves available. They like being partnered with a clinician and they offer themselves up for that capacity. And other times the decision's made based on sort of the sectors that the officer will be covering and what makes the most sense to give the most flexibility for moving around the district to field these kinds of calls. But we start to shift with the officer. We get into the cruiser with them. We are outfitted with radios, with vests for safety. And when the officer's signing on to the system within dispatch, they let the dispatcher know that the clinician from BEST will be riding with them for that shift. So the dispatcher then is aware that they can channel any of the calls that relate to EDPs, these emotionally disturbed person classified calls, or any other kinds of related calls, such as family trouble or man down, calls of that nature, to this unit. We don't have dedicated cars at this time, except for some of the work that we do with the street outreach unit, which is great. But that means that we're going to calls that aren't exclusively related to people in behavioral health crises. there are pros and cons certainly to that. One of the great things is that there are people in distress a lot of the times on calls that aren't designated as emotionally disturbed persons. So we're sometimes able to help with distressed family members, so the officer is able to attend to their duties, or people who are traumatized because of whatever incident, some crime has occurred, something such as that. But additionally, because we might be on unrelated calls, if a dispatcher is to dispatch a call to a unit that does not have the clinician because that clinician is tied up on a non-related call with their officer, the clinician's always listening on the radio. So when that officer wraps up those functions, the clinician's able to say, hey, there's another unit responding to an EDP call, a few blocks away. Could we go and support that officer? So both things are happening. The dispatchers are trying to send these kinds of calls to the unit that includes the clinician and officer co-responding, but then also the clinician is sort of screening the environment, both over the radio and on the computer and the cruiser, so that they can see what details are coming in and if these are calls that they think that they could be helpful with. So in one or the other of those ways, that brings the clinician and officer paired to the scene of one of these calls. And the clinician's doing their assessment. Initially, we want to make sure the scene is safe. If we're going to support an officer who's already responded to a call, then that's sort of already been taken care of before we arrive. But if the clinician and officer paired are the first to arrive on scene, the officer's making sure that there's no immediate safety concern, the clinician's getting involved, providing an assessment of the person's clinical needs, and then consulting with the officer so the officer can make the best decision around what to do next. So we're not dictating to the officers that this person must go to a hospital or they must not, or that we must provide some sort of service, but we're giving the officer an expanded menu of potential dispositions for that call than they might have without our consultation. So sometimes the clinical recommendations may be something that's sort of secondary that we might make to the person in need, but their criminal justice related needs may take precedence. And so we might be leaving information about the BEST team and perhaps, how as a follow-up or next time that might be able to be utilized. At other times we're sort of saying, hey, the behavioral health component here really takes priority and we need to get that person the care that they need, and that perhaps the criminal nature of whatever may have brought the call to light may not be all that critical. Perhaps it's an issue of trespassing or shoplifting, something that's maybe a lower level kind of crime where perhaps charges don't need to come from that incident, or maybe the person might be able to be summoned. And so it's really up to the officer to make that judgment call in that moment about whether it's going to be the clinical needs that are going to dictate the disposition, or more pressing public safety needs resulting from more serious criminal activity. So that's sort of that options piece. We're often in that moment working with EMS to help with transports if a person does need to be brought to an emergency department. So as you've seen on some previous slides, we have other resources available to us. Sometimes we're having a BEST mobile clinician come out and do follow-up because they have the luxury of a bit more time than the co-response clinicians have, since they're working at the pace of the police officer. Sometimes that's what we do. We leave the person and a clinician's following up. Other times we're sending the person to the hospital with EMS, and other times we're able, through this partnership with the police, to use that cruiser as an alternative transport to get folks to locations that they couldn't have gotten to without this interface, really. So these urgent care sites are, the way I describe them often, is sort of a psychiatric minute clinic. So it's a place that staff, we can bring somebody, make a warm handoff, help them get their needs met more quickly than in an emergency department, but there's certainly less structures in place around, people would not be appropriate to be brought there if they need to be restrained or medicated on site or those kinds of things. So we're making those decisions, and then as Tasha mentioned, trying to figure out what's the right way to get the person to those services. Sometimes it's EMS, sometimes it's on their own, sometimes BEST is coming to them, and sometimes BPD is doing that transport. And then the call gets closed and both parties document their efforts. As I mentioned, sometimes that might involve a follow-up visit from BEST. So the call might kind of shift from being a police-based call to a more behavioral health-focused intervention that can last longer. But the police intervention ends at that point. This is a slide that I use when training the recruits at the Boston EMS Academy. And it sort of highlights the way that our co-response clinicians are thinking about triage when they're in the community. So we're really kind of the legs for those urgent calls that come through 911 to try to figure out how to navigate this situation through potential best resources. And again, that decision ultimately rests with the police officer, but this is how we're thinking through what guidance we might offer to the officer in that moment. So the kind of most calm, lowest tier of these interventions would be pass off to a mobile crisis clinician. So we might make that decision if the person's safe to wait at home, wherever they might be. So they have a space to wait in, not sometimes we're getting calls to like someone's on a street corner. That might not be the safest place to leave a person, but we have to make a determination based on the environment as well as the person's presentation. These folks that are served most best by this intervention are people who are help seeking and recognizing that they're in need of some sort of service themselves, that they might be able to hold on until that next helper can come on scene, that it's not so critical that they can't be left to themselves or with another person to provide some ancillary support until we're able to get more clinicians back to their scene to assist them. So some of that might involve some limited safety planning around, should you start to feel worse after we leave, what are some steps that you could take, which is also always calling the BEST 800 number is included in that, as well as a reminder that 911 is always there, right? So if a person thought that this waiting would be fine, but it turns out it's not, we want to be able to leave them with information about how we could get back to them quickly. And then also Tasha talked about scenarios where it might not be safe to send a clinician by themselves. So again, I just mentioned like the person on the street corner may be difficult to locate somebody without an address or things like that if we were just to send a clinician on their own. So we're again evaluating what's the safety of the environment and what's the safety of the person. So for people who have a bit more urgency and their need to be evaluated, we might consider utilizing the BEST Urgent Care Center drop-off sites. So these are locations where, at this point, only EMS is not able to bring people to these settings, but Boston police officers are able to do that, safely transport, as well as we can guide folks to get there independently, or we can even assist with getting people cab vouchers to be able to safely access these locations. There are staff there on site, there are clinicians, as well as often family partners and peer specialists who can welcome the person to the environment, help them settle in. It's more of like an office-based waiting room that they're sitting in, getting all registered to be seen. So you can imagine that there are some presentations where that would just not be an appropriate type of environment to bring someone in crisis, but oftentimes from the de-escalation that we're able to do on scene, we're able to utilize urgent care so that these folks aren't unnecessarily utilizing and burdening the emergency department. And sometimes they're able to attach to whatever their plans are better because their experience was really smooth and quick, where if you're sitting for hours and waiting in an emergency department where they have all of the, the triaging and testing that has to be done for all their patients, sometimes that's not the best model for enticing people to follow up on getting their mental health needs met. So these urgent care sites really bridge that need in a really nice way. It is a voluntary environment in the urgent care site, so this is not a location where we would be sending people under Section 12. The person would have to be in agreement that this is something that they want to do. If they change their mind at some point during that process, they're able to walk out and suspend the encounter. So we are trying to be thoughtful about who we're bringing there and when we're bringing people there, and all of the best ways to meet that person's needs. And then there are certainly times where these are calls that are coming in as emergent through the 911 system, and sometimes we're getting to those scenes deciding that the behavioral health needs are going to take precedence in the disposition, and that we need to get this person to an emergency room for further evaluation, but in addition, more of the safety and containment. So that might be the best and most appropriate option if the person has any urgent comorbid medical conditions. So if they're actively overdosing in the moment, if they have perhaps self-injured significantly and they need medical attention to address those wounds or that kind of thing. Sorry for this jargon on this slide. High likelihood of means inpatient level of care as a disposition. So if from the community, this person's behavior is such where we believe that it is likely that they will end up needing to be hospitalized as a result of the evaluation, it may make sense to have that person just start their encounter in the emergency department, because that is where they will be waiting to be transferred to an inpatient facility for admission if, in fact, the case unfolds the way we anticipate it to when we have that initial triage in the community. And then if people are disoriented in the community, they're not sure where they are, who they are, time, date, place, that kind of scenario, that could be secondary to so many different things that it's not safe for us to discount all of the other potential reasonings for that. So that's another time when we're really looking for this person to be brought to the hospital. There's a lot more questions to be answered in those situations, so better to be safe to have all of those resources that one would have in an emergency department. So we often send folks there with the help of EMS. I think that's the end for me.
It is.
Thank you.
All right, you're stuck with me for the duration for the rest of the presentation. So some outcomes of BPD partnering with BEST, and there are a lot of them, and there's quite a few of these slides as a result. Just for comparison and as a kind of a demonstration of input and buy-in from the BPD, in 2010, when this kind of first started, a total of 25 people were referred to BEST by BPD. By comparison, in fiscal year 2020, we had 401 times that emergency department and ambulance ride transports were avoided. We had 10 people get holding cell evaluations. We had BPD seek referrals and consultations through the 1-800 hotline for 236 people, and they referred directly to the clinicians for 563 people. And also importantly, as Lauren and Tasha both mentioned, BEST is really important also for doing follow-ups. If someone has been a repeat call for service or high utilizer of services, having that proactive follow-up to try and prevent future calls can be enormously helpful and really help relieve the system. And we've had 216 of those in fiscal year 2020. Other outcomes, obviously, as you can imagine, is diversion from arrest. So it's important to note that about 66% of the times that BPD and BEST co-responded to a call for service, 66% of those were non-criminal behaviors. And the BPD is just going to be, that's a reality, is that people are going to call 911 for these types of situations. And it's really helpful to have the BEST there to help, especially handling non-criminal cases. But importantly, in 34%, there was criminal behavior involved. And out of those 34%, the total, which is 192, people were arrested only 27% of the time. Having a BEST clinician there, as Lauren mentioned especially, is a really huge tool for officers to have as an alternative to arrest. And even when arrest is required, and again, sometimes that is the appropriate response, there's also, BEST encourages BPD to issue summons instead of arresting on scene, which enables the BEST clinician to stay there, provide more help. The person can actually stay home and get summons to court at a later date, which really allows for more assistance in the moment. And as Tasha mentioned, a lot of training developments have happened over the years. Again, our initial federal funding allowed us to make an e-learning video about BEST, as I mentioned. Recently, we developed an e-learning video on Section 35s, which is mandatory detox. We're going to be making one for Section 12s, which have been mentioned a couple of times, which is mandatory psych evaluations. So we're working on that. Again, these are tools that are being increasingly used by officers that are hugely important. We've also had BEST come in and teach our officers at the academy. They're a part, every recruit class that comes through is taught by Lauren, usually with Dan Harlow. They get to know their faces, and they really kind of, the second they come in, they know who BEST is and how they can be helpful. And they also do other in-service trainings for veteran officers. We've also been getting CIT training for officers. So as crisis intervention team, which is a 40-hour mental health training for officers that's a best practice in and of itself. We've been very fortunate to get state DMH funds to provide backfill so that our officers can go to training centers locally, particularly in Brookline and Somerville, to receive these 40 hours of CIT training. We've had more than 110 officers trained so far, but BEST is always heavily involved in that as well. And even more importantly, we're looking into developing our own CIT training out of our BPD Academy, because part of the issue is when you're learning what the proper response is to a mental health related call, it really is important to know what your local service providers are and your local resources. So if you're going to Brookline to get trained or going to Somerville, some of it is kind of, it's training is training, but knowing what your local providers and partnerships are would be hugely helpful to know what to do in the moment. And so having our own CIT training through the BPD Academy would really just be Boston focused. And so we're working on doing that, and BEST would be a major partner in helping us teach, but also develop the curriculum. I mean, they'd be there from the ground up. And it's also important to note that when officers ride with clinicians, they receive one-on-one training. In just fiscal year 20 alone, we had over 160 officers who rode with clinicians. And those clinicians, those officers are learning on the go. They're learning how to fill out Section 12s. They're learning about the urgent care center. And so it's really wonderful. And I also want to mention, I think we've got at least a few of our clinicians besides Lauren here. So if anyone has questions for them, they've been just a phenomenal team. We also have had a working group. This could be a whole presentation in and of itself. There's this thing called the Boston Community Justice Project, which is part of a larger Massachusetts initiative initiated by the trial court. And I'm guessing maybe some of you have come to one of these, but we do these things called sequential intercept mappings, where you locate intercepts where you can try and prevent people with mental health and substance use issues from becoming involved in the criminal justice system. So you bring together partners from all along the spectrum and really identify where there are gaps and where there are priorities, and kind of improve connections and partnerships and collaborations. And it's a phenomenal project. Thank you to Marisa Hebel, who's been hugely helpful. And thank you to Judge Coffey out of West Roxbury, who really spearheaded this in Boston. And so for that project, there is a steering committee that BEST and BPD are both heavily involved in. And there's also different subcommittees that help to address the issues that are identified. And one of those issues that was identified from the get-go and at every mapping we've had is the need for more co-responders. So for a few years now, we've had this co-responder subcommittee that is largely composed of BPD, BEST, and EMS. We also have other partners, as you can see, like DDS, the Mayor's Office of Recovery Services, Melissa Morabito, who is our academic partner out of UMass Lowell, who's helped us do evaluations over the years. Everyone's involved. We've been meeting monthly for years now, and it's really helped to improve relationships across these different agencies. And it's going to really naturally evolve into a working group that, as we expand our BPD-BEST partnership, can really help guide that expansion and improve relationships, because we already have this great working group in place. So that's going to be huge. Other outcomes. I could also do a whole presentation on the Street Outreach Unit, who I believe is here today if you have questions for them, but they're a relatively new addition to the BPD. They are a proactive group of officers who reach out to high utilizers of services in a really unique and wonderful way. So of course they work very closely with BEST clinicians. And then we also can, again, that's Sergeant Peter Messina is here from there. Deputy Mike Stratton couldn't make it today, but they've changed the whole game, having their presence and their buy-in. We also have hub tables currently in East Boston and Jamaica Plain, but we just posted a job position if you're interested in a citywide hub coordinator. We want to take that model citywide. Again, I could go into that, but BEST and BPD both work closely together on that. BEST assists BPD with code 99s, which are barricaded individuals. So if someone's barricaded themselves and they're locked themselves in a room with a knife, BEST is on that call list. They're going to be there and help negotiate that situation and be on hand to provide mental health assistance. Dedicated car pilot program. We worked with Melissa Morabito on that as well. But as Lauren mentioned, our clinicians, when they ride with officers, are not in a dedicated car, which means, again, if they're with an officer and there's a burglary around the corner, they're going to have to go to that burglary, and the clinician ends up sitting in the car and waiting while the officer goes to assist. And it's not always the best use of the clinician's time. So we did a pilot program, I guess a couple of years ago now, I don't know, where we were actually able to use funds to have a dedicated mental health car, which made a huge difference, so that when the clinician was responding to mental health, that was what they were doing. That car only went to mental health calls. And when they weren't responding, they could do proactive follow-ups. And we found that the follow-ups, and Melissa can probably speak to this better when she testifies later, but the follow-ups play a huge role and really can make a huge difference. So having that better use of clinician time is just kind of a pipe dream, but someday having a multiple mental health cars would be great, just something to keep in mind. We've also been working really closely with Boston Public Schools. Melissa and I have been doing a bunch of research with Boston Public Schools and with our research partner, Jen Green at Boston University. We're also part of a mental health and crisis intervention coalition that's focusing on mental health in schools, and we meet regularly. And of course, Councilor Sabi George has a mental health providers roundtable that we all participate in, and she's going to be having an upcoming mental health commission that we'll be happily involved in. So BPD and BEST, since we kind of started this thing, have been doing just a ton of work together, and it's been a real pleasure. So that brings us to where we are today and our current gaps. So as you know, we have only 4 clinicians right now, which seems just so sparse compared to our needs citywide. And again, keep in mind that one of those clinicians is grant funded. So only 3 of them are stably funded through the operating budget. So as you can imagine, we're lacking coverage in various ways, including not every district, let alone area, has its own clinician. And even in those districts and areas that do have them, they only have them on 1 shift. So we have other shifts that aren't covered. We have specialized units that would benefit from having clinicians. The Operations 911 call center is something we're thinking about doing, having a clinician embedded there. I think we're going to talk more about that in a second. Proactive follow-up, as I mentioned, is a huge benefit of clinicians, and there's a gap there. We need more of that. Threat assessment, there's a whole other level that if Sergeant Messina is still here, he can talk about. But that's a whole level of the game that we're not doing it right now. And again, peer support. We have a part-time peer specialist now funded through our DMH grant, but having peer services is really important as well. And so we really could use more of that. And then, so now that we're up to $2 million in our current fiscal year budget, which is amazing, we're obviously going to continue to support the 3 existing clinician positions, but it's going to enable us to hire 15 more. So some things that we're thinking about doing are a full-time clinical supervisor. We have Lauren, who supervises now part-time, but we're going to have, a lot more clinicians now. So we're going to probably need a full-time supervisor as well. More district level clinicians, weekends, after hours. A couple of the specialized units that we think could use some coverage would be the school police unit, the family justice group, which includes sexual assault unit, human trafficking, domestic violence, and crimes against children. The street outreach unit would benefit from having one assigned just to them because they're doing that proactive outreach, and having a clinician with them who has access to everyone's medical records is hugely helpful. Operations 911 call center, we've talked about embedding a clinician in the 911 call center so they can triage calls as they come in, so they can not, so they can actually possibly help right there and just take care of things, but make sure they really identify what the call is and who would best assist, and possibly do some active assisting over the phone. And we also want to share these funds with Boston EMS, who's been an amazing partner, and the reality is that BPD and EMS are going to be working together on a lot of these calls. And so we know a clinician would also be hugely helpful for them. So we think we would like to have a clinician that could help EMS with follow-up as well. Their squad 80 would benefit from having a clinician. And they also have a grant coming through, it's called the ET3 program, that will enable them to transport to non-EDs. I think we'll ultimately want to have a clinician for that. So there's just so much we can do. Just to demonstrate buy-in, this slide just shows in 2010, when we first got a clinician, we kind of had to shove that clinician down a captain's throat. They didn't really, we tried to force it, and it took years for this program to really take root. And now when Deputy Stratton surveyed all the captains to see who would want what, they all came back with at least one clinician, including a bilingual in East Boston. The need is out there, but more importantly, the buy-in. The need was always there, the reality is, but the buy-in has been a challenge over the years. And now, as you can see, the captains are just really, they understand the value of this program. They all want clinicians, including the family justice group. It's just, the need is there, the want is there. So with respect to next steps, that working group I mentioned, as soon as we have this meeting, I'm going to get that working group going virtually so we can start really guiding the expansion of this program. I believe 5 of the positions have already been posted, just kind of generic clinician positions. So just the hiring process will probably take a bit. And we're going to finalize that budget and get going. So that's it. Thank you.
Jenna, thank you guys so much to the entire team for this incredible presentation. Denise and I were texting just to make sure we had all the panelists and talk about a timely update given all that we're talking about in terms of the collective trauma we're all feeling with respect to so much. So thank you guys so much for the thoroughness. Before I go to colleagues and including the lead sponsor, I just want to quickly, we have a few more folks to testify that we're going to go to. One is John Georges here. I think I see you. John, are you here? We're going to go to you to testify. Is that okay? Or do you need a few more minutes?
I just need 1 second to get into my office and close the door. How are you?
I'm doing well, and take your time. While you're doing that, I'm going to check to see if the other panelists are here too. Do we have Mike Ondrick? And I apologize, Mike, if I said your last name wrong.
Is it just you and I speaking right now? Are they on a pause?
So there's a whole panel here who can see
Okay.
you, but while you get set up, I'm just checking to see if Mike and a couple other panelists are available.
All right, sounds good. Thank you.
No problem.
Mike Vandrick is listed as an attendee right now, but he maybe could get moved into that particular.
Okay, Carrie, yes, if we can move Mike in, and then I'll also check, is Melissa Morabito here?
Yes, I'm here.
Perfect. So John, if you need more time, I can start with another panelist. We give you a few more minutes?
Yeah, if you don't mind, that would be great.
No problem. Take your time. Melissa, how about I go to you to provide some testimony, and then I'll go back to John and then Mike.
Oh, great. Okay. I'm Melissa Morabito. I'm on faculty at the School of Criminology and Justice Studies at UMass Lowell, and I've been working with BPD as an academic partner for the last 10 years, evaluating the co-responder program. In that time, I've seen the co-responder program grow in size, acceptance, and impact, and I fully believe that the program is ready to expand. So let me share how I know this. Over the last decade, I've been collecting a lot of data. I've conducted ride-alongs with clinicians and corresponding teams. I've interviewed officers and clinicians. I've looked at calls for service data and analyzed the information collected by the clinicians to learn about their calls for service. And we've learned a lot. So it's very difficult to measure the absence of a thing. I can't tell you how many incidents will potentially be escalated because of co-response, but what I can tell you is that the work of the teams is incredibly promising. Last spring, BPD conducted a dedicated car pilot that Jenna mentioned, and this meant that the team would be freed up to only respond to calls for service that involves behavioral health. And we wondered if there would be enough for the clinicians to do, right, and if there would be a good use of time for BEST and BPD. And the results were really exciting. First, the pilot confirmed that most of the incidents involving people experiencing behavioral health challenges fall within the gray area. So there are calls that are not serious crime, right, and could be addressed in any number of ways, okay? It was not surprising to see that the co-response team used formal responses very infrequently. The most common response was leaving the individual in the community, as Larry mentioned, and connecting them to BEST or to peer support, or both, okay? We also found that when the team was not responding to calls for service, they were using their time to do follow-up work. So follow-ups typically stem from referrals made by other officers, by courts, by schools, and people in the community. And sometimes even the individuals themselves would reach out for help. The combination of the clinician and the officer means that it's sort of a no wrong door approach, right? So the teams, given their different resources, are able to marshal all of the city resources for the benefit of community members who don't know where else to go or who else to ask for help. So also what Jenna, Lauren, and Tasha have not shared with you is that BPD is considered to be a leader in co-response. The Council of State Governments and the Bureau of Justice Assistance have both pointed to these often as a success, and this is without clinicians available to every district. So I really welcome the expansion of the co-responder program with this funding. And I'm particularly excited because over the past decade, we've been doing the hard and unglamorous, but super important work of putting data collection systems in place. So we have baseline data, and we'll be able to track the work of the new co-responding clinicians and their impact on Boston. There will be accountability and clear outcome measures from these new clinicians. And I just want to say that it's really been a pleasure to work with the city on this program. Thank you.
Thank you so much, Melissa, and thank you for your work and your testimony. I will then go to John, and John, are you ready? If not, no pressure. I can always go to Mike.
Hi, no, I'm all set. Good morning again to everybody, and thank you for, inviting me for the testimony on this very important matter. I know that you guys are all working hard as a collaborative, and there's been many instances, in the city that definitely need this very meaningful service. I just want to introduce myself and my background. I've been in the EMS field for about 20 years. 10 of those years were spent working for Boston EMS as an EMT, and I currently work in the Commonwealth as a firefighter and paramedic, and manage a very large ambulance service as my second job. So two things is the combination of having the best team working with Boston Police is a very meaningful resource, as everyone's kind of illustrated, and I appreciate that. But on the unilateral side of things, I wanted to share with you guys my experience of having to use you personally and how stressful that was, because it's hard to be objective when you have a family member in crisis and you're put in a vulnerable position. So I heard that everyone discussing code 99s and, people with co-occurring disorders, and for those that aren't clinically familiar that are sitting on the panel, that's somebody with underlying mental health condition that's complicated by drug and alcohol abuse. So back in April, and this is one of many instances, I had to lean on Boston Police and EMS for an issue with my family member. That resulted in a code 99 situation because it wasn't handled in a manner that it could have been. And it doesn't mean that it was wrong. It just means that there wasn't fundamental training like, Lauren and her other colleagues had expressed. And it resulted in a code 99 situation when there was a potential weapon and it was freezing out. And we were outside for over 90 minutes trying to negotiate the paranoid state, drug-induced paranoid state that my family member was in the South End, and it caused an entire street block to be closed. But her arriving to the scene with Dan from Boston Police and that unit that you guys are funding really minimized at the end of it when he came out peacefully, which, he normally would, but we didn't know what we were going into. She was able to de-escalate him, make him feel safe, and given her clinical master's level background and understanding, the collateral behind everything when we got to speak, he was assessed by EMS, he was cooperative. She was able to get in touch with Mass General in our affiliate hospital, and we were able to get him on a Section 12 psychiatric hold where they were able to medically clear him, which gave me time to go to the court in the midst of COVID, by the way, where we're still trying to figure out how to allocate resources for people that suffer from co-occurring disorders. And I had to have this telephone conference with the judge and the affidavits, and Lauren was able to help advocate from the BEST team with the clinicians, the psychiatrist, and the doctors at Mass General to find him reasonably unfit and hold him on a Section 12 until I could get the court, because it was a Friday, right? So we know that a Section 35 is a civil commitment warrant of apprehension, and you send someone, essentially after the process in the court system to go to a psychiatric and substance abuse facility for up to 90 days. Typically it's 21 given the capacity limits that they have. But anyhow, that Section 12 hold and Lauren working with Boston Police in combination with Boston EMS, she was able to grease the wheels and get my family member the resources that he needed, the care that he needed, given the circumstances of the evolving and fluid COVID situation. And regardless of COVID, this is something that's ongoing all the time, right? So I heard a lot of people say a lot of important things. So, and I agree with all of them, right? At the end of the day, he got what he needed, and it gave me time to get this Section 35 done. Had it not been for her and Boston Police working together, he would have been discharged from that hospital, and we would have repeated it again. And unfortunately, despite the Section 35 that was issued, he was released early, and that's a state level issue. That has nothing to do with the city of Boston. But it happened again in my own home, which is why this is personal. He came to my home where I lived and broke in in a paranoid state in a multi-dwelling home that I've lived in for almost 18 years. I'm a constituent in Boston and been there for 20 years. And being a first responder and feeling unsafe, I contacted 911. I contacted my family. We had another Code 99 situation. And again, Dan responded in, and Lauren communicated with me immediately. And we were able to use the court system to have him committed for a competency to stand trial, which gave us that layer of protection to go into, I believe it was Bridgewater State Hospital, and get psychiatric evaluation and get these resources. But none of it would have happened without Boston Police cross-pollinating with the BEST team. I think that is the best collaborative that could ever happen. In 2001, when I started working for Boston EMS, which is a division of the Public Health Commission, which I hope everybody knows. I'm certain that you do. Again, it's just to echo, preceding all of these efforts and collaborative, I haven't worked there in quite some time, but it would be, can we have Boston EMS respond or start EMS this way? Because the officers didn't have that training, and that wasn't a fault of their own. It was given the call volume and the crime that they were facing. They would never Section 12 somebody. We would have to physically restrain them, safely take them to the hospital. And now that we have these resources, I understand there's concerns around law enforcement around the country. There's all sorts of layers of things that are happening, and we may have the community think that it's not a good idea to have the police respond, but it actually is if they're trained. Dan and Lauren have to be the best team, no pun intended, that I've ever worked with, even as a professional. I would love to have that resource available here in the community that I work in. I work for the town of Natick, and we have those very same calls right now. I'm the ALS coordinator here. But with respect to Boston, you guys have all these amazing, we have all these amazing resources. I'm a resident of Jamaica Plain. I'm a constituent. I support everyone. I support everything that we need to do. But without that team effort, it wouldn't have went well. It could have been a bad outcome had she not been there and had there not been that proper training. So I know there's stigma around the police, but with proper training and the safety concerns that we were faced with that day of weapons, firearms, we weren't sure given his paranoid state. We could have had a catastrophic event on 2 occasions within 30 days of each other. So this co-response, this tier response that we're working on, it can't go away. It has to be built upon. There has to be more officers trained and more people like Lauren that are available to assist the community. And I think that funding is so important for better outcomes under, Section 12s and Section 35 processes, and thinking of people that have co-occurring disorders. I'm in my office right now, and I just had someone throw something at me. And I just want to bring 2 things up too, I've gotten my point across about my personal story. We give this out like it's candy, okay? Narcan. Everyone see that? We give this out like it's candy for people that have opiate addiction. We spend millions of dollars in the Commonwealth on opiate addiction, and no one's family is immune to some type of substance abuse or mental health issue, right? So what lies between it is the stigma. And the reason my family member didn't want to get help for his mental illness and for his substance abuse with stimulants, which created the paranoia on top of his mental health disease, which led to these multiple encounters with Boston Police and with EMS, was the fact that the resources and training weren't so readily available because they're pressed on issues like hyper-focused on only opiate addiction and co-occurring disorders. So by not having the police respond or be involved with just having a civilian BEST team master's level clinician go out without a police officer is a huge risk and safety issue. And look what can happen to EMT McAllister that worked for Boston EMS. A coworker that I had a woman with co-occurring disorders, and she was stabbed and could have died right in front of the courthouse on Devonshire Place. the response from Commissioner Gross and members of command staff from Boston EMS from that EDP that was outside of a fire station in East Boston for 20 minutes is another example of why clinicians can't go into a situation without a properly, meaningfully trained police officer that can gently approach a patient. So even now, any single call in the city, hey, example, Boston EMS sends ambulance 2 to Roxbury for an EDP. They have an EDP 2 and an EDP 3. I don't know if it's changed. We'd have to ask Chief Woolley that, or someone from Boston EMS if they're on the call. You send the police to calls. That's been like that for decades. We always send the police to these calls. And if we're failing them by not having these trainings, or at the moment, not getting them in, we can't send EMTs in because we lack the ability to protect ourselves. If you're sending a civilian clinician in to go in and do an assessment, it's a nightmare not sending the police in for them. Just even the way it was handled when the SWAT team came and how the training that the BEST team's already done with Boston EMS and Boston Police, it was a 180 from the training that we had when I worked there for 10 years. So I can't thank them enough for everything that they did. I'm happy to report that my cousin is stable, he's medicated, he's sober. He continues to be, thankfully, to the resources in the city of Boston, Mass General, and support from us, and especially actually from the district attorney's office, because they weren't out to criminalize him, nor were the police. Their goal was the second occurrence of the Code 99. The DA told me at West Roxbury District Court, this screams treatment, 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 and recovery. Mandated by the court, maybe under stipulations or whatever, but the nexus was the BEST team was involved with Boston Police. They even showed up at the court to assist me and speak to the DA and give them the collateral behind it. Had they not been in place, I don't know where me and my family would have been. I really don't. So I don't know if anyone has any questions for me. I'm not a shy person.
We'll come back. I'm going to allow one more person to speak for a few minutes, but then go to colleagues. I know a couple of colleagues had to jump and they're going to try to come back, but we'll come back and open it up once I let one more person speak, John.
All right, thank you.
No, thank you, and thank you for sharing. Really appreciate it.
You're welcome.
So now we'll go to Mike. Mike, are you there? Mandrick, am I saying your name right?
Can you hear me?
Yes, we can.
Awesome. Thank you. Thank you very much. So my name is Mike Andrick, and I'm the director of the Pine Street Inn's outreach team and our DMH match team, which is a modified ACT team. I'm a master's level clinician. I've been working with the homeless for the better part of 27 years. For the last 7 years, I've been here at the Pine Street Inn. I'd like to start by thanking members of the Boston City Council for their support, especially Councilor Asabi George for your commitment to the homeless and those in need. I can't tell you how grateful I am that you come out on the vans with us and you see the world through our lens. So thank you. Special thanks to the Department of Neighborhood Development for their support with the daytime outreach team, specifically Jim Green and specifically Sheila Dillon for their leadership. And of course, just special thanks to Lydia Downey, a leader second to none in her work with the homeless. Additionally, Lydia also walks the walk. For the past 34 years, the Pine Street Inn has been on the streets at night with our outreach vans. Over the last 5 to 7 years with the city's support, we've also developed a robust presence during the day with over 15 clinicians and outreach specialists. I oversee both those components. Homelessness in general has many root causes, including poverty, high cost of rental housing, trauma, addiction, folks that are struggling with their mental health, domestic violence, and also systemic racism. For those on the streets at night, addiction, mental illness are at the forefront. Each night, our outreach vans see between 100 to 140 people, unsheltered, homeless men and women. Our goal is to keep them safe and to get them into housing. We use contingency management to build rapport, trust, kind of on the front end. Last year, we housed 150 homeless men and women in permanent supportive housing. The Pine Street Outreach Department works every single day with Boston PD's homeless addiction, behavioral health, and homeless teams led by Deputy Superintendent Mike Stratton. We partner with the BEST Clinicians led by Lauren Snyder. Lauren is known as the best of the best of the BEST team. Lauren Snyder is incredible. She's innovative, she's passionate, and really, really knowledgeable. Because of Lauren's leadership innovation, we're able to tackle problems citywide through the lenses of a social worker and with the clinical expertise that BEST has. BEST, with its current 4 clinicians and co-response approach, has made a difference in our work. If BEST were able to increase the number of clinical staff, we can do so much more, and we know that the need is there. We've partnered with Lauren and her teams on countless occasions. Some of these situations have been behavioral health crises related or involved homeless persons struggling with the traumatic brain injury and addiction. Having the BEST team embedded in law enforcement departments across the city has enabled us to provide the appropriate intervention needed for persons on the streets. The appropriate intervention could be the homeless person to go to an emergency room for medical care. The appropriate intervention could be a detox or shelter placement. There are times that this leads to a crisis unit placement, a Section 12 intervention or a Section 35 intervention to ensure the immediate safety of homeless individuals for themselves or others. BEST Clinicians embedded with law enforcement across the city, has assisted the outreach teams in placing individuals who are imminently at risk to themselves or others in an appropriate hospital level of care setting to stabilize. Frequently, psychiatric stabilization occurs, and these individuals have been placed in Pine Street Safe Haven programs or directly into permanent supportive housing, embracing a housing first thinking and action approach. When we have a square peg round hole presentation with lots of complexity in that presentation, eligibility for services or housing, we've been able to access the best services with law enforcement to achieve great outcomes, preserving dignity to those in need, struggling with both untreated mental health and also addiction challenges. Pine Street readily partners with co-response teams as it relates to substance abuse services like detox, post-detox, Section 35 treatment placements. This partnership ends up being a continuum of sorts for individuals struggling with addiction, where they step up into a higher level of care, right? Like it could be it could be High Point out of Brockton, it could be Plymouth, it could be the RAP program in Taunton. And with our clinical services at Pine Street, what we end up doing is we go to these places weekly. We meet with the individuals, we engage them in recovery-focused resources, and we step them, ideally, we're stepping them right into housing and recovery services. So that partnership that we have with Mike Stratton's team, with Lauren, is just incredible. And I cannot state how important it is. The Boston PD and BEST team also assist us with stepping a person out of a 35 into recovery services, housing, and mainstream benefits. So big kudos to Mike Stratton's entire team and Lauren Snyder. I can't thank you enough for the work that you guys do day in and day out. By the City of Boston embracing this co-response system that readily partners with the Pine Street Inn and many other homeless stakeholders across the city, we've been able to thread the needle with many homeless persons who have challenging presentations. And I'm going to talk a little bit about 2 of those presentations towards the end of this. When we can offer a joint response with Pine Street and BEST, and yes, the Boston Police Department, we create better outcomes. There are dangerous situations with potential safety issues where we know homeless people are at risk. We know our staff are taking a risk by intervening there. There are some locations at varying points across the city that have limited egress areas. So it's always nice to partner with Lauren, anyone from Mike Stratton's team, particularly Danny Carlo. Danny has just mad mental health skills. Danny does a great job. So it keeps us safe, it keeps the clients safe, and it keeps our team safe. I mean, we're out there every single day, every single night. We're committed to the mission, vision, and values of the Pine Street Inn. So, partnering with this co-response system really keeps everyone safe, and we just have better outcomes. We know our staff are taking risks by intervening there when these situations arise in the city. We always partner with the co-response teams that Lauren quarterbacks. We just have great outcomes there. I do want to take a minute to just talk about two examples that stand out to me. One is a person by the name of Joe, who'd been homeless for the past 15 years, residing on the streets, mostly in Back Bay, and he'd struggled with untreated paranoid schizophrenia. Joe had recently had his blood pressure taken, and his blood pressure, no joke, was 224/138. On a 96-degree day with the heat index of 102, Joe was dressed in layers of clothing, including a tattered snowmobile suit and a winter knitted cap. Joe had been known to be aggressive in his presentation, and we were collectively concerned with him potentially having a heart attack or a stroke. Joe was deemed imminently at risk to himself and potentially others. Through a BEST co-response with Lauren, Officer Danny Harlow, myself, the Pine Street Behavioral Health Outreach Team, we partnered to develop a plan to assist with a Section 12 intervention. This plan needed this intentionality to include the hospital of choice where the section was written to and how we approached Joe on the streets. Historically, Joe had become assaultive and also had a history of eloping. Through our collaboration, we were able to safely transport Joe to a hospital where he received much-needed medical care and psychiatric care to stabilize. Joe remained in the hospital for 45 days, recompensating medically and psychiatrically, and transitioned to one of Pine Street Inn's Safe Haven programs. Joe has remained housed for the past year in the Pine Street Safe Haven, stable psychiatrically and medically. Another example I'm going to give everyone is a person by the name of Sam, who had been homeless for the past 9 years, struggling with both chronic and acute health issues with an amputated leg and being wheelchair dependent. Sam also struggled with alcohol dependence. It was common for Sam to be seen by the Pine Street Behavioral Health Outreach teams during the day, the OVAN or overnight services, local ERs, the police, and EMS. Sam was one of the highest utilizers of emergency services in the city of Boston, frequently found unconscious or in precarious situations while under the influence of alcohol. He'd been found by the state police on Route 93 in his wheelchair. Pine Street Outreach partnered with the co-response team with Boston PD and BEST to intervene as Sam was imminently at risk to himself with his struggles with alcohol dependence. The co-response team and the Pine Street Outreach team moved forward with the Section 35 that led to stabilization of Sam's struggles with alcohol abuse and both his chronic and acute health conditions. As Sam continued to stabilize, Pine Street assisted with stepping Sam down into the Pine Street Post-Detox program at the Shattuck campus. Then Sam stepped into permanent supportive housing at Pine Street in Jamaica Plain. This was a joint effort with many shared decisions between Pine Street, the co-response team, to stabilize and place him in housing. We placed one of the highest utilizers of emergency services into permanent supportive housing. Sam is still housed today, a year later. What I would share with this group is miracles happen every single day when we partner with the co-response team. Counselors, we know street homelessness is important to you because you care, and we know it's a priority for your neighborhoods you represent from a quality of life standpoint. As much as we've done together to move homeless individuals off the streets and into housing, we know there is so much more to do. Supporting BEST expansion and supporting the co-response approach will be an effective means to ending homelessness for more people. I would just like to thank all of you today for talking about this important issue and just recognize Lauren Snyder for her innovative work with the BEST team, and also Mike Stratton's team, Danny Harlow, the whole crew. They're amazing. So I would personally say thank you, everyone.
Mike, thank you so much. And frankly, after all those discussions and even some of those heartbreaking stories, to end on a positive, hopeful note, really appreciate it. So thank you so much. And also, of course, thank you to BPD. And I think some of the panelists suggested this, obviously, in the time period in which we're in, especially talking about policing, we often don't highlight all the great work that our police department is doing, whether out of the grants division or with respect to these issues. So thank you so much, and thank you to our administration for still being on. I'm going to turn this over to Councillor Sabi George, who I think is then going to introduce Sergeant Messina and allow him to introduce his team. And then if Councillor Sabi George has a few more questions, feel free to just continue. Thank you.
Great, thank you, Madam Chair, and thank you everyone here for, Jenna, Tasha, and Lauren for the very thorough presentation. Just really appreciate it, and I continue to learn every single day about the tremendous work that you all do, and I hope that my colleagues found that presentation worthwhile. I think that they did, and I received text messages during the presentation to that effect. Mike, John, and Melissa, thank you for your presentation today and sharing both your work and your passions and your personal experiences, because I think that when we see this work in a PowerPoint and then we hear about it in practice, it makes it all more real. And I know Peter's here, Peter Messina with his team from BPD that are doing this work every day. So I'd love to give Peter an opportunity just to introduce his team, but also talk a little bit about how co-response and his outreach team work sort of every single day, and sort of give us, if you don't mind, Peter, just a snapshot into the sort of day-to-day work that you're all doing on behalf of our residents. Welcome, Peter.
Thank you very much, Council. My name is Sergeant Peter Messina, assigned to the Street Outreach Unit. My officers who are also on this call, Officer Claire Duffy, Officer Dan Harlow, Officer Josh Delay, Officer Josh Della Rosa, and Officer Artie DePino. So our mission as with the Street Outreach Unit is to promote community-based outreach through partnerships and collaboration to those affected with mental illness, substance abuse, disorder, and homelessness in a professional, humane, and supportive manner. Our main mission with the Street Outreach Unit is proactive prevention, intervention, and de-escalation. This partnership with the BEST team allows us to accomplish this mission, especially the prevention, intervention, and de-escalation segment to it. Our day-to-day operations, one question I had, I'm trying to keep track of everything that we're doing, but one of the main things for this past year since we began back in October, I'll use October 1st, we responded to 9 Code 99s, all involving mental health, individuals suffering from mental health crisis. And those were 9 successful situations that allowed us to intervene, de-escalate the situation, and to get the individual into treatment safely. I was involved in a couple of them. I know Dan and Lauren were involved in a lot of them as well, along with Claire and Josh Delisle. One that I was involved with had to do with an individual who was allegedly in his apartment with a rifle. Full call out of all the SWAT team, the entry team to possibly, and a hostage negotiation team to de-escalate the situation. But the individual who was involved in this just was off his medication. We were able to divert this individual, give him a ride over to Boston Medical Center so he can get on track to get the proper medication. These are some of the things we do daily. A lot of the individuals that we deal with in the Massachusetts area and citywide suffer from substance use, but they also suffer from mental health issues as well. And these two issues intertwine. Having the BEST team there with us to deal with these situations on the spot at that moment is amazing. It's a great tool on our tool belt to have, and increasing the size of the BEST team, in my opinion, is essential for city services. I only see positives to it, and I think I'm going to pass it off to my team. Talk a little about different situations they've had. Just a quick synopsis of different things they have done. So I'm going to pass it off to Dan right now. I'm not sure how to do it, but Dan, if you can just unmute yourself and kind of just give a quick
Hello,
overview.
everyone. Here we go. Good afternoon. Everybody hear me? Excellent. First of all, thank you, Council Lisa George, for setting this up. All the other councils for joining, Jenna Savage as well. Thank you to Peter as well, and the whole rest of the team. I know my name has come up a lot. However, this work can't be done without Officer Duffy, De La Rosa, Delisle, and DePino. We are truly a team. They do just as much work as I do out there on the street. So I guess a couple examples of what Lauren and I kind of do. One that comes to mind is a 9-year-old girl who's out in Brighton. She's got some severe trauma history and some mental health issues. This young woman does not like the police. When mom has to call 911 for her, she tells the officers to stage away from her house, one police officer only to respond and walk up to the house, because law enforcement traumatizes this girl every time they go for whatever trauma history she had in the past. The first time that Lauren and I went, we wound up talking with her and discussing with her. Lauren was able to look at her history through BEST, and we figured out what the issue was with her when law enforcement shows up. Long story short, by the end of this call, I was the only person that she would allow to be in the ambulance with her and follow her to the hospital. She would not let me leave her hospital room until her mother showed up. Doctors and nurses were not allowed to come in the room without me being present, just because the trust was there and we were able to communicate with her and understand what was going on with her. So having that level of knowledge with the BEST team clinician with me allows the officers to actually refocus on how they view and how they're going to interact with an individual. The second story real quick is another individual out in Brighton who had been repeated 911 calls to the house. The first time it wound up being an officer in trouble call. This individual is about 6'3", 6'4", 260, 270 pounds, and he was fighting the officers there pretty well. Just about the whole district responded to get this individual under control, and he was sent to St. Elizabeth's by ambulance. He was evaluated by St. Elizabeth's and then released the next morning. From that incident, there was, I believe, 3 or 4 more 911 calls to that same address from him, and he had actually gone to the station as well and followed officers around the station and threatened them. Every 911 call that went to that house, the entire district that was available would go because they knew this individual from the first incident. If it wasn't for Lauren being able to have access with the BEST records and us being able to communicate with the district and what was going on, then we wouldn't have had an outcome that we did. We wound up reaching out to family members to figure out what was going on with him. From the help from family members, we got a little bit more history. This individual was ultimately diverted from just being arrested on all these charges and everything going through the court system to be diverted to Bridgewater State Hospital, where he needed to have more treatment. And then the charges are going to be pushed into mental health. So ultimately, at the end of his stay there, hopefully they'll be diverted from actually doing jail time, and he'll get stabilized and be in a better situation. Those are just 2 examples. I've been with Lauren for the last 2 years. I've been a police officer in Boston. I should have said all this at the beginning. For over 20 years. And from the start of my career, arresting people and sending them to court and seeing the outcome of sometimes something happens, sometimes it doesn't happen, to now actually diverting people, even sometimes using the court to divert people to get treatment. The outcomes are static. I used to hate court because nothing but now seeing that the courts want this and want people to get help instead of going to jail has been a complete flip, and the court has been good. And just working with Lauren has been ecstatic. So let's see him pass it on.
Thanks, Dan. A few of my other officers would like to just give a quick 1 minute or 2 minute. Thank you very much. I'm going to pass this off to Artie DePino.
Hey, how's it going, everyone? Can you hear me all right?
Yes, good morning.
Good morning. So, I'll say the full response is very good. Going to a scene that's a crisis with the best clinician and you have all their information and the background on the person that you're going to assist, it goes a long way with how you respond and how you handle them. Instead of just thinking it's someone who's committing a crime, if you have their name already and you could have a little bit of the backstory, it gives you the game plan on how to approach them. But in addition to the crisis calls that we go on, we also do a lot of outreach. And with collaboration with Pine Street and the BEST team, we go around different parts of the city, Nubian Square, Mass and Cass area, Eggleston Square. And it's great because we offer people services when they're not in a crisis situation. And the other day we were out, I was with Mike O'Neill from Pine Street and Lauren Schneider from the BEST team. And we were just outreaching, talking to people, giving them some cold Gatorade, asking if they need any help. And one of the ladies started breaking down and she started kind of going into a crisis. She was talking about her drug use and her mental health history. And it was amazing having a BEST clinician right there with us because it was the easiest way to connect her to services. So we all talked and see what we could do. Lauren was able to de-escalate her, tell her several options of what she could do from that point forward. And it was just a situation that if we didn't have a BEST clinician with us on scene, just doing outreach in the community, that individual wouldn't have got the help that she needed at that time. So in addition to the 911 calls, that they're a great resource, they're also good going out and doing outreach and helping the people in the community that might not get anyone else's attention on a regular day. So that's the story I wanted to bring up.
Thank you very much, Artie. I'm going to pass this on to Josh Delisle.
Hello, everybody. So I just want to pass along a quick story. Not too long ago, I was working with one of the BEST clinicians, and I got a call from Project Place, a social worker over at Project Place, who said she was speaking with a gentleman that was one of her clients that was suicidal and in the Andrews Square area. He had called her numerous times and was talking about his ideas of what he wanted to do. And it was perfect because I was working with one of the BEST clinicians, and I was able to pass the information to her so we could get a little bit of a background on the gentleman we were dealing with, or hopefully going to be dealing with in a positive way. It took us about an hour to locate him. He was riding the train back and forth and getting off various stops, and we ended up meeting up with him at the Andrews Square station. I got a bit of a description from him and was lucky enough not to be wearing a uniform that day. And kind of approached him and said, hey, my name's Josh. Your social worker called me and said, you might be, thinking about some things. And he was a little bit hesitant at first, and going in with some background information from BEST was certainly helpful. And the clinician was on standby a little ways away because we weren't sure exactly what he was going to be doing, what his ideas were. We ended up walking from Andrews Square all the way to 85 East Newton Street to the walk-in clinic for the BEST team. And on that walk, he had no idea I was a police officer until we got to about Topeka Street. And at that point, he was not only excited that I was a police officer, but that we were there to help him and get him the services he needed. The transition from the phone call that we got to meeting up with him, the long walk, which at times seemed like a lifetime because of the things he was talking about, but then the ease of walking into 85 East Newton to get him the help that he needed and having the clinician with us to transition into that facility, it turned out he was also COVID positive. So he went from there to the hospital, but maintained contact with me during his hospital stay. And continue to express his appreciation that the two of us were there to make his life easier and to make sure he didn't do something he shouldn't have. To this day, he's still doing pretty good, and I attribute that to our relationship with BEST and the way we were able to handle that situation that day. So just a quick story, and thank you for listening.
Thanks, Josh. Next, I'm going to pass this on to Claire Duffy.
Good morning, everybody. Thanks for letting me speak. One of the things that I wanted to talk about was how we have tools on our tool belt when we go to different calls. And prior to this, I worked in C11. I was there for about 10 years. And prior to that, I was in Mattapan. I was there for 3 years. And then I was a civilian in 911. One of the things that attracts you about coming to this job is problem solving. And up until we were given the BEST team, access to the BEST team or being able to ride around with them to co-response, it became quite difficult because the only thing that you could do was call EMS and then hope that whoever was in the ER that day would be able to help that person, or refer the parent out to the pediatrician to reach out and get a referral to a psychologist or a counselor, and then hope that you wouldn't have to come back to the house again. And when you have to keep going back and forth constantly, it could be really, really difficult. And one of those experiences that I had at C11 was we had one of our BEST team clinicians, her name was Jen. I was assigned with her that evening, and we went to one of our houses that we went to every single day for the same problem. Somebody was suffering from mental health issues that were not being appropriately dealt with. There were about 3 or 4 police officers already in there when I got in there with the BEST team clinician, and he was very upset. He was yelling, he was screaming, he was intimidating people. It was not, a inviting situation. So Jen came out from behind everybody, addressed him, spoke to him, and he was immediately validated. He was immediately disarmed. His tone of voice changed, his whole temperament changed, and he was able to hash things out with her, make an appointment with somebody at BMC. She was able to follow up with him to see what was going on. She was able to give services to the family members on scene, give them advice on what to do. And that's not something that we could really do. So I just thought that was fantastic that we were able to do that with her, provide a situation to a family that was having the police in their lives every day, which is, hard. You don't want that kind of situation to happen on a daily basis. So I'm grateful that we have this opportunity, and I hope it continues and it expands. Thank you.
Thank you very much, Claire. I have one last officer. I just don't see his name on here. Officer Josh De La Rosa. Who's
I thought I saw Josh. Let me see. You can always come back to him too as well once he gets on.
Yeah, maybe he fell off. He's no longer in the the attendee list.
Oh, I see him as a panelist. Aiden, do you see him? My son Aiden sees Josh. I see his name listed here.
No,
Josh.
I think that's the other Josh.
Oh no, that's the wrong Josh. Sorry. We'll come back to him.
Okay, thank you.
Great, thank you. Thank you, Madam Chair, and thank you for allowing Peter and his team to introduce themselves because they're doing a lot of this work day in and day out, especially around the areas and some of the effort around mass and CAS. So I just want to thank them, and I know the program pretty well, so I'd love to just give the rest of this opportunity to colleagues to ask their questions and engage with both Jenna and Tasha and Lauren, but also Peter and his team, or Mike and sort of the interface that some of our nonprofit partners have with the efforts and the work on the street. Thank you, Madam Chair.
No, thank you, Councillor Sabi George. And I will tell you, normally these hearings, it's the councillors doing a lot of talking. So it was nice, frankly, for us to really listen to you guys and give everyone an opportunity to really talk about the critical work you're doing on the ground every single day. We don't get to hear this often enough. So thank you. And of course, thank you to the partners on the ground as well. So I think Councillor Braden had to jump, but she's going to try to come back on. I also know Councillor O'Malley had to jump to an appointment as well, but it's grateful for the work you're doing. So now I'm going to go to Councillor Flaherty. And if Councillor Flaherty isn't on, Councillor Flynn, and we can go back to Councillor Flaherty if he's able to get back on. Councillor Flynn, you have the floor.
Thank you, Councillor Campbell and Councillor Sabi George. Both of you have done excellent work on this issue for many years. I want to say thank you to the BEST team for the incredible work you're doing in our city. You're saving people's lives. You developed a great working relationship with the Boston Police. And as we often say, we can't arrest our way out of problems, and the BEST team is playing a huge role in helping so many people dealing with many challenging issues. So I want to say thank you to the BEST team. I also want to say thank you to the residents of Boston and the Boston Police as well. These are difficult and trying times for everybody, but I also know that we have an excellent city workforce. Everyone plays a critical role in part in what's going on in our city. The police play an exceptional role, as does the BEST team and our drug counselors, public works team, parks department. But I just want to say thank you to our dedicated city employees for always being there for the residents of Boston, especially during these difficult times. Thank you, Councillor Sabi George. Thank you, Councillor Campbell, for your work on this important issue.
Thank you, Councillor Flynn. Councillor Flaherty, are you on? I see your picture.
I'm on it, Madam Chair. How are you?
You have the floor.
Very good, thank you. I obviously want to thank you, obviously, for hosting, and for Councillor Sabi George for her great work in this space over the years. She's been a leader and has been a great and positive reflection of the council in this space. So kudos to the great work that she's been doing. I also recognize the numbers in terms of if we're going to continue to support this, then we need to continue to fund it. And early on in the call, on the Zoom, we heard that in the vicinity of about 10,000 calls a year, and it seemed like it was a little bit of a low number in terms of just everything that goes on, and that just round numbers, that's about 30 calls a day. I'd love to see a dedicated patrol car for just this, and let's beef up the program. The gentleman, I think it was John Georges, had described kind of how in real life it plays out, and that couldn't have been more accurate. Had a very similar experience dealing with the situation last fall, and my time as an assistant district attorney, when these situations arise, particularly when there are weapons involved and it's a domestic type of situation, they go from bad to worse really quick. So I guess I have a question as to the folks on the clinician side is I'd love to get a sense as to what their response time is from the moment that call comes in to the moment that they pair up with the Boston police officer and then they get to the scene. I think response times are critical if we're going to continue to promote and to push and to fund this program, very much like we have measuring sort of metrics, if you will, for our response times for police, fire, and ambulance. I think this is a critical, the best in trying to have the right and a more appropriate trained people responding to 911 calls. That has to be a piece of the equation. And then wanted to see, I guess, what it would take if we had a dedicated car or two, and so that they're out, listening to the radio, they're tapped into it, and then when a call comes in, and again, on average, that's about 30 calls a day. And there are some neighborhoods, and I looked at the chart that was described, there are some parts of our city that don't have that type of coverage. Area C, for example, didn't have any want to assign to them. There are a couple of questions, but I want to thank everyone, particularly the clinicians that are on here, to my assistant TA days. Oftentimes, families will, instead of calling 911, they'll actually call and what I saw when I worked in the DA's office is oftentimes, depending on where the doctor lived, the doctor would then call 911, call it in for sort of a well-being check. So not sure if the well-being check is listed as those calls. So then the clinician would be at their home. They would call in. The Boston police would do a well-being check, and then they would check back with either the family, or the family would then call the clinician and say, yep, police came here, they did a well-being check, and this is what happened. So eliminating sort of that, I think, needs to be part of the discussion too. So if we're going to get clinicians involved, and we either have a dedicated patrol, folks are not calling in well-being checks to 911, they should be going through the BEST system as well. So that's just, again, personal experience in situations that I've dealt with in another capacity. But that's it in a nutshell, and I appreciate everyone's work and attention to detail here. This is a great program, and look forward to continue to support it and to continue to support the lead sponsor and you as the chair. Thank you.
Thank you, Councilor Flaherty. Let's see, I'm looking to see.
And who best could answer the...
Right, I'm going to ask if that could be you, Jenna, or Jenna, I can have you defer to another team member. It could be Sergeant Messina. It's up to you.
I was actually thinking Lauren might be good.
Oh, Lauren, okay, sounds good. Go ahead, Lauren. Thank you.
So because we are embedded in the cruiser with the officers doing co-response, we're not at a third location that they have to come and get us. So as soon as a call comes into 911, we're en route to the call. So once that gets dispatched out. So similarly, working with a regular BEST call center 1-800 number, they're usually quoted within an hour that a clinician will get there. So sometimes that's just fine. But there are times where it isn't. So having the ability to be able to get there right in the moment when there's something that is more emergent is really helpful. And then on calls where police only response happens first, just out of timeliness, because the unit with the co-response clinician is tied up on another call, then it might take as much time as it takes for that unit to free up from whatever they're already tied up with to come support the officer who's arrived first on scene. But because of coming with officers with lights and sirens, we're not having to worry about traffic and parking and all of those kinds of things that slow all of us down getting to some of these calls that come in through our more traditional means. So it's very, very helpful to be coming there with the police for sure.
And I'll just mention, as Councilor Flaherty mentioned, Area C not having a clinician, they did have one for a while. It was BJA funded through federal grant funds. And it just plays to that point of having to rely on grant funds. And so we definitely intend to fill that gap with these funds. But again, it's just the importance of having it in the operating budget for more stability.
Thank you, Jenna, and thank you, Lauren, for that. I'm now going to go to Councilor Baker.
And just Madam Chair, just to that last point on Area C, they did a realignment several years ago with the district courts. So, and I'm not quite sure if everyone realizes, but the Mass and Cass, a lot of that activity there, that actually now goes to Area C6, that actually goes to South Boston District Court. So anytime that there's a section or an apprehension, it goes there, and they don't have, at one point they actually had a court clinician at the court who's no longer there. I don't know if they retired or through budget cuts, but that's an area that I think needs to be addressed, whether it's through BEST or what have you. So I know that there was one, there isn't one now, and that flow, that Mass and Cass flow, doesn't go to B2 anymore. It actually goes to C6. It doesn't go to C11, it goes to C6. So I think that Area C, and maybe this is a broader discussion with, I wish we had our partners in the courts on this at this hearing as well, just to give you their perspective as how it plays out, particularly during the sections that John George just had described earlier. But there's sort of a missing link, I guess, to this conversation. But I just want everyone to know that that's what happens. It all goes over to C6, and there's no clinicians that are available to address that. And it's pretty voluminous Monday through Friday up at Southie District Court. So that's that flow from Southampton Street that comes down through Andrew Square that ends up on East Broadway through the court process. And so if we could give some attention to detail on identifying or making sort of that part of what BEST does, that would be great. And if we need additional funding, then sign me up. I'm happy to help because it's a big issue. But thank you.
Thank you, Councilor Flaherty. Councilor Baker, you're up. And then after Councilor Baker, I'll go to Councilor Mejia because I think Councilor Bach had to jump off. Councilor Baker, thank you.
Thank you, Madam Chair. I'm just more want to preach to the choir here about the good work that the clinicians and the police side are doing here. I have more interactions with probably the police officers, and I would like to use it as an opportunity to thank Peter and his crew, but in particular Claire Duffy, who's actually working with my office right now on an issue that's been an ongoing issue, and it's mental health and addiction, and she's been great. Just wanted to give her a shout out. But these are the types of things that I think with the national discussions that are going on, I think this is the way policing needs to happen. One of the points that I heard pretty clearly was the importance of police being paired on with the clinicians, because we don't want to send clinicians the same way that when EMS would go on. We don't want to put those people in harm's way. So I just more want to say informative hearing. I enjoyed it, and I look forward to doing the work, and hopefully this upcoming year we can maybe get in front of this a little better when we normalize and are able to actually work under normal circumstances. With all this going on here in the city of Boston, we heard Mr. George talk about how he wished that I think it was Natick had access to this type of program. So I just want to make sure that everybody knows we know the good work that's happening, and look forward to working with you all. Thank you, Madam Chair.
Thank you, Councilor Baker. Councilor Mejia, you have the floor. And Councilor Bach says thank you. She had to drop off.
Thank you, Councilor Campbell and Councilor Sabi George for hosting this and helping us get up to speed with all the amazing work that is being done on this front. It was very informative. An hour and a half and almost 2 later, I think I got my full understanding of all things BEST. So thank you for that tutorial. Really do appreciate it as a freshman counselor to be well briefed on, everything that's happening in the city. So I do appreciate the presentation. So I just have a few questions. I'm just curious, everything that I do, I always come from a cultural competency lens. Really do appreciate the team that's here today. Just curious in terms of your leadership team, if there are folks of diverse backgrounds that are part of your think tank and forming your decision and the type of programming that you roll out. Just curious because I see that I always pay attention to who's in the Zoom or in the room and who's not. And so just curious about the diversity on this level here and what that looks like.
Sure, I can take that. As far as I know with the clinicians, we are definitely seeking to diversify. Currently we have 4 white women, I believe is what we've got. But so we're definitely seeking and again, even just bilingual. So this is an exciting opportunity to bring on a more diverse team of clinicians. And as far as the think tank goes and our working group, we're not the most diverse group. It's something we've talked about also in the community justice workshop group. It's a tough issue. So we are working on it, and it's something we're aware of, but I think we can do better.
Do you know what makes it so tough? What are some of the things that you're struggling with and how we might be able to help support the work?
I guess the people who seem to be involved just don't seem to be very diverse right now. I guess that's the best I could say. But literally we're making a concerted effort to improve that. And I don't know if anyone can add to that, but it's just, it's a tough situation that we're working with what we've got. The people coming to the meetings just don't seem to be diverse.
Jenna, if I could actually, I think I have some that I could add, and maybe Tasha from BMC could also chime in if through the chair. And we've learned this through some of the work on the mental health roundtable. Is one of the challenges with creating a more diverse field of providers is access to academic and educational opportunities, the licensing process. When we think about student loans, when you're going to college to become a master's level clinician, and we recognize and realize that there's a real challenge within the academic field to better train providers that reflect the community, and making sure that we have providers that are both culturally competent and linguistically competent, but also reflecting sort of making sure that it's our city's kids that are looking to engage in these career opportunities. So that's a topic that's come up in great detail when we think about the mental health roundtable, because we are always looking for and want to grow the field in the profession. And there's also some concerns around pay equity and an opportunity to make a salary in that field that could help pay back the student loans that so many of our young people find themselves having if they're to go into this work, and the role of an advanced degree, especially around clinical services. But Tasha, I don't know if you could speak to that through BMC. And we also have, and I'll share with colleagues, the job postings for these clinicians and this funding through BMC, because we want to make sure that our networks have access to these postings. Sorry, Madam Chair, for taking sort of liberty there, but that's a very specific item that's come up both in this work in particular, but through the mental health roundtable.
I'll also mention, I just want to mention too, I just got a text from one of our clinicians who is on this call but doesn't want to publicly speak. One of our current clinicians is in fact Puerto Rican, which I had not realized. And she provides a lot of bilingual services in East Boston. So we've got that. And Leon, if you want to speak up, I would encourage you, because I think you do phenomenal work in Area A. But if you don't want to, that's totally fine too.
And thank you, Jenna. And thank you, Councilor Sabi George. That's what I was going to add, just a little more specificity that our Leon and as well as our peer specialist are both Latina. So just add that for a small amount of diversity to our current staff, but agreed that absolutely hiring police correspondents as well as all of our best clinicians who are representative of the diversity of the Boston community is a key metric, certainly from the Boston Medical Center perspective, and I think something that we're looking at very specifically, and which is included in the job posting as well, that we have preference for candidates who do represent the diversity of the city of Boston. So absolutely something that we're looking at in terms of hiring additional clinicians at this point.
Yeah, I do appreciate that. I'm just curious in terms of just partnerships. I know that through the work that I've done in the past, we have a whole entire network of clinicians of color who are practicing here in the city of Boston. And so I'm more than happy to send you a list of all of the ones that I know who are highly engaged and have done a lot of work with the Boston Public Schools in regards to trauma-informed practices, and have facilitated and participated in many ways. So I'll be more than happy to put you in touch with some of the clinicians that I know are doing this work. And there's one particular group that's on Facebook. It's the Mental Health Advocates and Practitioners of Color. I think it's a good group for you all to tap into. And just, I think that there are some other folks out in the community, like Toy Burton. She may not be a clinician, but she's definitely doing a lot of work in Roxbury and other parts of the city around mental health. So I'm just really, for me, it's always about like, how do we expand the table and how do we create more spaces for different diverse voices to help inform the thinking. So I just really, I don't call it out just for the sake of calling it out. I really do call it out because I do believe it's an opportunity for us to help support the work and find ways for us to be engaged in those conversations. So I offer myself to be invited to your roundtables, and, you know, by all means, I'm a busybody. So please feel free to engage me in this process, because our office is doing a lot of work around mental health, specifically working with young people in this space. And so I think that that is also, for me, it's an area of interest and of my own personal lived experience, why it's so important for me to help support this work. So moving on in terms of just other, I'm just curious about some of the cultural competency training that BEST team receives. I know that Mr. Madrick mentioned systemic racism as a factor that impacts your work. So I'm curious to know how the BEST team addresses that factor.
Great, thank you. So we provide, in addition to a number of other ongoing areas of clinical competence, regular yearly trainings that are available to all staff members on issues of, well, in the past it had been issues of cultural competence and how that impacts our clinical work with individuals. I think things that we are planning to include this year, which, you know, of course is very timely given the state of the country, are around specific trainings around microaggressions as well, which can certainly impact and interfere in our work with communities of color in the community. So that is planned for, I believe it's planned for early winter, you know, and I think it's something that we need to work to incorporate into all of our trainings on all areas of clinical competence, but those are some specific ones that we have included or plan to include up to this point.
And in terms of your, you know, the RFP process for the trainers, just curious in terms of what opportunities are created for women and minority businesses who are doing this work to come in and do your training. Is that one of the things that you look into or no?
Typically, when we're looking for trainers, we have certain required areas of competency that we have to train on based on our contract with the state. So typically what we're doing is whenever we have a content area, putting it out to a network of providers and then seeing what response that we get. But, you know, it sounds to me like there could be a more specific process that we could engage in to really attract or enhance our ability to work with you know, minority-owned, women-owned businesses and trainers. And so I think that's something that it's an excellent point that you raised, and I would like to figure out how to incorporate that moving forward, maybe with your assistance.
Absolutely, thank you. And I'm also just curious about the BEST team and the different types of languages that are spoken aside from English. And, you know, what that process looks like when there's a call, like, is there any language access support that you need additional or anything like that? Can you just talk to me about language access?
Yeah, absolutely. So we have staff members who are bilingual, bicultural individuals who are native speakers of Spanish, Haitian Creole, Cantonese, and Cape Verdean Creole. I'm sort of speaking a little bit off the top of my head, but I know all of those individuals, so I'm certain that those ones are correct. And then if that individual is an individual who speaks that language is not immediately available at the time of a call, all of our clinicians have access to BMC, interpreter services who can be engaged in real time to provide telephonic translation. So a language, you know, if we don't have a clinician who's a native speaker of a language, that will not prevent us from responding to a call. Certainly we prioritize staff who are bilingual to go to calls where language capacity is an issue, but with the use of the interpreter line, we are able to accommodate. I don't believe we've ever had a situation where we're not able to accommodate a language need.
And I know you mentioned earlier, or I think one of the officers did, in terms of how an officer assesses whether or not an individual, if the case is warranted, you know, any further, I think it was arrest or something, or it might be a low level. I forget what it was, but I'm just curious about how that determination is made. Is there some training around deciding who gets deployed to what calls?
Are you speaking from the legal perspective? I just want to make sure I understand the question.
I don't know I don't know what perspective I'm speaking of. I'm just curious about, like, how do people decide what type of services the individual is going to get? I don't know. I'm just curious. I wish I could remember what it was who was talking about it at the moment, but it was something that resonated for me, that I'm like, well, how do they determine what their course of action is going to be?
Well, so I can speak for that if that's all right.
Yeah.
So we've done a substantial amount of training with the BEST team. So how it works right now is every day the shift is pretty much covered from morning until night, where there's at least one BEST clinician, if not two, working. If a BEST clinician is needed citywide, it could be in Brighton, it could be in Roxbury, Mattapan, Hyde Park, wherever. The operations goes all out for my unit along with one of our clinicians, and we respond with whoever is working that day to the call. So at the call, the great thing about having this co-response is that at the call, we're collaborating to figure out what the best course of action for this individual is. Our primary, what's what I'm looking for. Primary course of action is always de-escalation and diversion from the criminal justice system. We've learned, and I've learned in my 15, 16 years in this job now, that diversion is the way to go. I always thought the courts would handle everything, and as I'm getting older now, I understand that that's not the case. So diversion is huge, and that's one thing that my squad is trained on, and my squad focuses on. I have Josh actually De La Rosa just popped on. If we can loop back from before, Josh, if you want to speak for 2 seconds, to talk about diversion.
Well, yeah. So, Councilman Mejia, if that's okay, to let Joshua respond to your question. He was off earlier, and then I'll let you go. I'll go back to you for any additional questions you have. Thank you, Councilman Mejia. Joshua, go ahead.
Hey, Mr. Mejia and everybody that is on. God bless you guys. Y Dios le bendiga. So yeah, so there is the unit is a little diverse. We also have a Portuguese brother on the unit, but in terms of co-response with the best team clinician, I think it's one of the best things. I don't know if we even have time to share any testimonies, but I'd like to share stories. So like, for instance, Mattapan a couple months ago, they contacted our unit about a guy that had over 200 911 calls. And it was so bad where the guy was camping out inside the ATMs and it was just a problem. He was even defecating on the sidewalk. It was a big mess, not to get into all the details, but one of the best team clinicians decided to go with me. Her name is Laura Bullis. We went over to to Mattapan, and we were able to speak with him, and by the grace of God, we got him the help he needed, and he hasn't been out there terrorizing Mattapan, and he's connected to the services he needs. And I think it's a great way to just handle a lot of the situations that people look down upon, and I speak Spanish, también parle tu petit Creole, a little bit of Creole, but it's a blessing.
Thank you. Councilor Campbell, could I continue with some questions?
Go right ahead.
I'm going to use all the time that all of my colleagues were not here, so I'm going to take 30 minutes.
I don't know that we have 30 minutes.
I'm teasing. So
no, you go ahead. Thank you, Joshua. And then I'm going to ask a few questions and I'll go back around too, but you go right ahead.
So Joshua, before you go, I'm just curious, are you a police officer too? Is that what you are?
Yes, ma'am.
Okay. So when you first learned about the BEST program and this initiative, what was your initial reaction as a police officer? Did you think, can you give me what your journey was from first hearing about the BEST and the collaboration and kind of like what you have learned as a result of it?
Well, I think it's a great question because when I initially thought about CIT training and working with best team clinicians, I didn't it's new to us, and anything in change in policing, it's like, what are they doing to us? What are they bringing they're trying to change our culture, but they offer the CIT training, and I'm like, you know what, let me just try it out. I heard about Section 12s. I didn't know nothing about Section 12s. It was taught to us in the academy for a brief period. And if you don't practice, you're never gonna know about it. So being on the job, dealing with people that have issues with mental health and not knowing what to do, it's one of the biggest things because I kid you not, 90% of the radio calls we get are either emotionally disturbed persons or domestic violence. So by being able to have all these tools, besides a mace, handcuffs, and a firearm, we have the tools of such as services to be able to connect these people, and I think that's one of the best things. So at first, I gave it a little pushback, but it opened my mind up, and it even teaches you how to speak with some of these individuals. And some of the medical terms that you don't even know, like excited delirium, that's something you would have to go to school to learn, and you learn that by some of the training you take. And so I think it's good.
Thank you for that. And then I'm also, and Councilor Campbell, just one last question, okay, if you don't mind, just one quick one.
No, go ahead.
Okay, I'm curious about, I've been hearing a lot about the mental health and homelessness and issues around substance abuse. I'm curious about other traumas that people face, whether it be, sometimes people just lose a loved one and they just had a quick episode that has nothing to do with a mental health issue or has nothing to do with substance abuse. So I'm just curious about what, if any, incidences you guys have come across that, around my way. There are a lot of situations like that have nothing to do with mental health or substance abuse, but it definitely has something to do with an ability of an emotional, traumatic experience that you have yet to face. So I'm just curious about those scenarios.
Yep. So absolutely. So aside from being a police officer, I'm also a full-time pastor. And I always say there are times where I respond to a call or I come across somebody and I say, this is a God moment. This isn't a police moment. This isn't a mental health moment. This is a God moment. And something as little as a quick prayer or just giving them some biblical advice or just some counseling, it breaks a lot of chains and you see the person go on about their day and on with their life with just a simple conversation. And so, yes, there is moments where it isn't always a police moment and it isn't always mental health problem.
And are you, because I don't know how these ranks go. I'm still learning about I'm new in this job, but are you like a police officer? Are you a sergeant, a lieutenant? What are you in the little rank and file situation? Where do you fall?
So we haven't gotten there to detective or sergeant yet. So I'm still a patrolman, regular police officer.
And how long have you been in the force?
Going on 6 years.
Okay. And so I'm just curious in terms of, I'm not advocating for anybody to get promotions, right? But I'm just saying, like, I think that it's important for us I love the way you think. And I think more in terms of the narrative that's out there around police officers, I think that we have gotten so far away from humanizing people that, and this goes humanizing both the police officers and the people who are out, like, there's so much civil unrest between, just everybody these days. And I think that the more spaces that we can create for conversations like this, where people can see humanity and see, regular folks like y'all, having conversations from a heart-led space. I know that sounds kind of wonky, but we don't lead with the heart. And I think that is what is missing in our society, right? And I know that this is not a public hearing to have a moment of like, utsa, or kumbaya, but this is so simple. We as human beings make things so much more complicated than what they need to be, right? And I think that, I don't know, I'm just really grateful to have been in this space and have learned a lot about the work that you all are doing to support our most vulnerable residents. And it was great to have you, Joshua, to participate with us, to give us some perspective. And I hope that you move on up in the ranks so that you could take your frame of thinking and it should become, a way of being. So thank you. Thank you for your leadership in this space. I really do appreciate it.
Thank you.
Counselor, better now. Follow up on Councilor Mejia and that last question you asked. It's not within our unit, but however, BMC does work with Boston Police Homicide Unit, the Youth Violence Strike Force, and the Community Justice, I think, group. There are trauma-informed counselors through BMC that actually work directly with them. So like a victim of a shooting or a stabbing or whatnot, they get all of these cases and they work with homicide and the Youth Violence Strike Force to help these families out and get them into services that they need. So as far as like BEST is concerned at our unit, we're not quite the mental health people that would go with that, but these individuals are specifically trauma informed through BMC, through a different group than BEST, that would actually be linked up with homicide and youth violence strike force that would reach out to these families and help them out as well.
Thank you. Thank you, Daniel. It's nice meeting you all and seeing some of you for the second or third time. Peter, I know I saw you at one of the earlier meetings back in January.
Yeah, good seeing you again.
Yeah.
Thank you, Councilor Mejia. I just have a, and thank you to Joshua for getting on, and thank you, Sergeant. I keep wanting to call him Superintendent. They need to make you, I guess, Messina Superintendent. But thank you for jumping on, Joshua, and I know we were waiting and looking for you, so I appreciate you joining us to provide your perspective.
I apologize on that. I didn't eat breakfast, and you know when you get hangry and you have to step out and eat something, so. But thank you.
Totally understand. So thank you all. I just have a few questions. I saved mine to the end just to be courteous to the panelists, of course, and my colleagues. So I'll try to go through quick, and maybe the first directed to you, Jenna, based on just the presentation, or I guess anyone could answer it. One was, you were talking about, the data and the outcomes. Everything you had in your presentation was just so helpful. I mean, not just talking about the services you provide, but one of the things you talked about was how the limited coding, so how the numbers just aren't really reflective, frankly. So what is the barrier to coding more of these calls to get a real accurate description of not only what the department does, but what the need is?
That is a phenomenal question, and that's an issue nationally. This is definitely not just a Boston issue. I think there's a lot that has to do with call taker training. And I should also mention that our co-responder group, which is turning into a working group, we also often have regular representation from our operations, from the 911 call center. Chris Markunis often comes. But, I think that the police involvement starts at the 911 call, and I think the questions that get asked are hugely important. And I think that's also why having a BEST clinician housed in operations might be, really a game changer for asking those questions and really kind of triaging and figuring out what the issue is. But it really does all come down to call taker discretion and training. And so again, this is a national issue of really not having any sense of the actual scope of mental health calls for service. Because again, other than the ones that are just a really obvious black and white, like this is clearly a mental break of some kind. But again, mental health is a part of so many calls. And, even just over the years, we've pushed just to have a mental health checkbox, like kind of like there's one for domestic violence, like, is this a mental health related call, just to give us some better sense. And that's a thing we're still actively working on. It's still on our radar, but it's really hard to track.
No, I mean, and I fully support anything to eliminate those barriers. And why I even brought it up was not just based on the data and painting an accurate picture, was much of the work that Councillor Flynn and I are doing with respect to domestic violence, sexual assault, all these types of cases clearly fall within what we're talking about today, but may not be captured. So I will clearly work with Councillor Sabi George on any barriers there. So that's really helpful. One of my other questions had to do with, before the council, we're talking about so many different reforms, I'll put that in quotes, but just different ways to improve our delivery services, right? And specifically out of our police department, and moving away from just having 911 calls, but looking at how we use 311 or other ways in which people access different services through different entry points. So clearly this co-response is really important. And I think Councillor Baker got to, and maybe, I think it was John that got to this too, which is the importance of having an officer there with the clinician. So I guess I really would want to hear your perspective, or maybe this is for you, Sergeant, soon to be Superintendent Messina. As we're considering situations where non-police officers go out or respond, right? Clearly in mental health cases, you want clinicians there, you want experts there, but in certain circumstances, there seems to be a need to have an officer. When might there not be a need for an officer? What does that look like? And how does that connect to this larger conversation of not just having 911, but using other ways in which to have other people respond to certain types of cases?
So thank you. That's a good question. So one of our things that we're trying to do, but due to lack of manpower and lack of best clinicians, where it's making it difficult, is we're trying to do follow-ups. So a lot of these calls come in as low level, like EDP calls. It could be a person screaming on the street. It could be someone banging the floor of their apartment. In there, to a lot of people, they're minor calls. A lot of the officers, they're minor calls. What we'd like to do is follow up on those minor calls to see what the issue is, do more due diligence into that call. Because a lot of these situations, they involve a person that may be suffering from some sort of a mental illness and they're not taking their medication. And to know that we can get a clinician out there to have just a one-on-one discussion with that individual could resolve so many calls that may come in down the road. So calls like that, very low-level calls that may be a nothing thing, could be a quick incident report, quick call log. Those calls should get diverted over to a BEST clinician, not involving a co-response with the police officer. Our job as co-response is more of an escalated level. So when the BEST clinician goes out there and assesses the situation on these low-level calls and says, okay, well, this is more of this individual, John Doe, they're in our system and they're suffering from X, Y, and Z, then we could co-respond with them to the call. So that's how I feel that could be beneficial, having BEST clinicians respond on their own initially.
And I do think it's
helpful. Go ahead, Jenna. Go ahead.
I was going to say, it's just also so important to note that 1-800 number that was at the bottom of the slides. Again, I hope we'll make it public, but I think just getting that word out that the community can access BEST directly. And I'm sure there are so many situations where people don't want to call 911. They don't want an officer, but they kind of feel like there's nothing else they can do. So that's part of the best part of the co-response program, but also just this hearing is getting the word out that people can contact BEST directly. And oftentimes a BEST response, if it's not urgent, that will avoid police altogether. And that's part of this program. That's a great part of this program, is taking the police out of the equation where the police aren't needed, because that's, that works well for everybody.
Mm-hmm. And it also includes making sure that those other numbers and channels are staffed, right? And that's part of the conversation, funding and staff, which Councilor Sabi George, of course, has been pushing for years, to have the capacity so when folks call, there's a quick response to those calls. So that's helpful.
Yeah.
I just have two more questions. One has to do with under what circumstances, because we've talked a lot about diversion and moving people away from going to court, getting arrested, but under what circumstances do you typically see someone get arrested, right? Even if we're talking about folks clearly who have mental health concerns, but there is some data that suggests there still might be an arrest. When does that happen? What does that look like? What's a factual scenario where someone still gets arrested? And then how do you then go to some type of diversion knowing that there might be a mental health concern or something, or substance abuse or something else there?
So I can speak. Dan, are you still listening or somewhere?
I can hop in here too if you'd like.
Go ahead, Josh. Go ahead.
Thanks, Josh.
So I'd just like to say, one of the main focuses of our unit is creating non-arrest pathways to treatment and recovery. And so one of the things that we need is more tools in our toolbox for that. And having the BEST team and having all the other resources in and around the city to direct to the clients that we're dealing with is one of the most important things for us and for society. We understand that when we are, in essence, forced to lock somebody up for a crime, that creates a backlog on the system, but also adds another line to their record. And so if we can avoid that to try to change their life and break whatever cycle they're stuck in, to point them in the right direction, that's a win for everybody across the board, the person that we're dealing with and the services. And so I think education, more resources, the ability to work with BEST more often. If we don't have the tools when we get to the job, we can't use them. But having resources like BEST and like the other things that are in and around the city only make our job easier and people's lives better.
And just one.
But if others can chime in as well. Claire, do you want to chime in?
Yeah, I just want your reference to data of somebody still getting arrested, even though, we're responding with a clinician or we're taking other measures. The only thing that popped into my head was that if a family member is called because somebody's going through something, whatever it might be, 9 times out of 10, it's domestic related. So if the police respond, even if we come with, a BEST team clinician, there's still going to be some data received on the BEST team side where we can relay that to court. We can even go to court and advocate as to why this occurred. but by law, we are mandated to lock up somebody that hurt the family member or their significant other or something like that. And our hands are tied and we are, forced to do that. That's the only thing I could think of. I'm sure there's other situations where, we don't have any place to put this person or something like that, and they've committed such an egregious act that they do have to be locked up. But the domestic situations are the first things I would think of.
And one thing, I'm sorry, just to cut in, that I like to,
thank you, Claire.
very important is training. I know Josh is heavily involved in training, Dan, Lauren. It is huge to not only take it's huge to train us as a team, but also for us to train the rest of the Boston Police Department, the Boston police officers. Society's changing. This world is changing. We need to pass on these skills to the officers that are responding on the street. One thing I've learned in the past, time I've been on the job is that the BEST team is being utilized more and more and more. De-escalation is being used more and more and more. And that's important to get out to the academy to teach these new recruits that are coming in these new skills. I think training them from day one on this is huge. And that's something that we're trying to chip away at now and moving forward this next calendar year.
No, it's very helpful. And I support funding whatever you guys need, including, obviously the work with the external partners and how we can support them too. So thank you. And my last is just on the positions. There's a lot of new positions, which is fantastic. The hub position, obviously we've been going back with Jenna, with your whole team on that, which is really exciting. That there was funding for that. But I know Councilor Sabi George is going to get that to the council because there are organizations that are doing the work right now. I always think about Fathers Uplift in my district, which works with a lot of folks recently incarcerated. A specific population, but very diverse in their team, who would love to see these positions and to then give them out to their network with the hopes of increasing diversity. So look forward to receiving those and sharing those. And then on the data piece, and I'm curious if, and this is my last thing, I guess I could go on and on, but on the data piece in the slides, curious if you break it down any further by whether it's the outcomes, the dispositions, or anything by neighborhood, by gender, race, ethnicity, income, if there's other sort of markers, which I think help connect to other issues that folks might be going through and other policy considerations too. So just curious if the data has any demographics or any other information that might be useful.
I'm going to defer to Lauren on that because all of the data that we showed, and Lauren, I hope that I didn't just put you on the spot, but basically all of our co-response data comes through BEST.
Okay. Thanks, Jenna. Thank you, Lauren.
Certainly. Sorry, two speakers in one room. So we do track date of birth for calls for people who we have that information on, who have disclosed that. So we could break it down by age because we have staff generally sort of geographically placed within a district. We have that. We do track like the address that something happens or the home address for a person, which is oftentimes homeless because those folks are living in public spaces and then draw a lot of attention to anything that they're doing as a result. So we have information about where these events are happening and the age range, but we don't currently track anything about cultural or racial breakdown at all. We track how long calls usually take us, whether they're where the calls come from, whether they were referred from 911 or sometimes even directly from community providers, things like that. Can I make one comment about the last question that you posed as well? Absolutely. About the arrest piece? I know myself, and I think that this is true of all the clinicians, that there are the calls that we're able to get to, that there's a clear issue on scene, that the person has mental health needs, and our consultation on the scene is requested. But then there's folks that it may not be so clear on scene, and then the person's arrested because there was something, serious going on in the community. And as they're trying to book the individual and get through that process, it becomes clear that there's something that's just the communications breaking down, that they're having difficulty having this person respond to like simple commands. And it might be at that point that the clinician becomes involved, and where we decide, or we consult and say, could this person potentially be summoned instead of being booked so that we could get them to a hospital? Or there are cases we've consulted on, cases where the person's been arrested for murder. There's nothing more serious. The person needs to be in the containment of a holding cell. However, that doesn't mean that they won't also have mental health needs that we can help to address. So we can intervene at any point. So sometimes diversion is, like the gold star, the gold standard, but realistically, it's not always clear. And sometimes there are cases where it's just in the interest of public safety that arrest can't be avoided, but that doesn't mean that we just kind of walk away. We still try to offer assistance. We get involved. I think Jenna, I gave her the statistic of 10 formal holding cell evaluations done by co-response clinicians in the past year, but there are so many more that aren't full-fledged evaluations, that safety in the cell is maintained, but that the person's still struggling, or now that they're in a cell is an opportunity where they're realizing the writing's on the wall and something needs to change in their life. And so clinicians are often enlisted to help in those moments, to engage that person in some discussion, to help motivate them towards some change, and capitalize on those epiphany moments that sometimes happen when people do suffer those kinds of consequences as a result of their behavior in the community. Sometimes we're also able to reach out to family members or staff in group home settings, places where people may have psychiatric medications being held, and we try to coordinate with those parties to get those medications brought to the station so those folks can be medicated while they're being detained, and communicating any ongoing mental health concerns to the clinicians at the court so that they know that they're receiving somebody who may continue to be really struggling. So there is a place for this role that is beyond just diversion from arrest, although that's of course like very important, and at any point we can do that. We'd like to try to offer some other pathway, but there are going to be people that for public safety's sake cannot be diverted, and I think that is something that I hope we can track a little bit better in the future about, what are those other tasks, and quantifying whether that intervention from a co-response clinician shaped the outcome, even if diversion from arrest was not possible, even if we couldn't or didn't need to transfer that person to a setting of care, but that we were able to push that envelope in some direction to help motivate them to change, or to introduce them to some services they can follow up on themselves once they're out of custody, or educating their family members if we're calling and saying, could you please bring his meds by? Here's some resources you may not have known about. So I just wanted to share that in response to the questions about arrest.
No, that's very helpful, and I appreciate that. No, extremely helpful, so thank you. And I'll just end before I turn it over to the sponsor for any closing remarks or anything final. On the data piece, I think at some point it would be great to gather any other demographics, because I think it helps inform policy discussions and other things we should be working on. So whether it's neighborhood, gender, race, ethnicity, it's all connected, right? And so I really appreciate the presentations today. And I really also appreciate everyone sharing specific stories as to how this work shows up on the ground and in the community. So thank you. And Councilor Sabi-George, thank you for calling for the hearing. I'm going to turn it over to you.
Great, thank you, Madam Chair. And before we log out, I do want to make sure that we don't have additional public testimony.
I totally forgot. I started with some, but didn't. Yeah.
Good.
Thank you.
You're welcome. No, thank you. I do want to note that during the presentation that we had highlighted the BEST hotline number, the 800-981-HELP, H-E-L-P, but because of the closed captioning through our feed, it was blocked through most of it. So I'm going to reiterate for the public, and I ask my colleagues if they're going to share this or tweet about this share on social media, that they also include the BEST hotline number, the 1-800-981-HELP, H-E-L-P number, because that is an important number. And although we are working to upsize and what I think is right size our clinical support here in the city of Boston through the co-responder model with BEST clinicians, that BMC does have a 24/7 hotline available for any one of our residents to call, or our community members to call and reach out for help. And I think that that BMC partnership, the Boston Police partnership, and the work that continues in community, that this sort of co-response model with the partnerships that are here today with Pine Street Inn and so many other organizations, that it does really highlight, this work really highlights what true partnership can do to support our residents and our communities across the city. And I think that this, and the mayor's investment through his budget that we passed the end of June, really will go a long way. And I'm really excited to get these new providers on board and onboarded, and appreciate the work that they'll be able to do for our residents. And we'll share those job postings. I'll share those with colleagues so that they can share those job postings for with all of our networks, our respective networks. And I want to note that some of this investment also will go to make sure that that salary question is also responded to, that we're paying our co-responders wages and salaries that they need. I'm certain that it's not going to be as high as that we need it, but I do want to recognize that that's been a real concerted effort with Jenna and her team through this work and through evaluating where co-responders should be assigned and placed and available. And I do want to appreciate, I don't know if Peter had said this or one of the other police officers had said this, sort of the evolution of the use of clinicians on the street and the real partnership, again, that's created, and the support that it's offered our residents who are in a time of need. And I think that John Georges, during his testimony earlier, said it best when speaking about his loved one, that he got what he needed when he needed it. And that's really the impact of a co-responding model and having those providers available, is that we can get our residents the needs, respond to the needs that they have in their moment of need. And I do want to just uplift, because it was brought up a few times, but the Boston Community Justice Project that I've had the benefit of being a part of over the last few years is really sort of an extension of this work, and that work continues. And want to thank Jenna in particular, but the entire team that's here today and more, for holding one of your meetings at City Hall at the beginning of this year. I thought to myself, oh wow, that was a couple of years ago, but no, it was just the beginning of this year that your regular meeting was held at City Hall, and you welcomed in my colleagues to hear about that work prior to sort of your more formal meetings. So I am excited about the next steps. I'm excited about this investment and getting and onboarding providers, and making sure that we're in this constant state of evaluation so that the providers are where they need to be. So thank you, Jenna and Lauren and Tasha and and the entire team, Peter, Joshua, Dan, Claire, who I think is still on, and Artie, because I interact with you guys both through these meetings, but seeing you do this work firsthand, and it really is it's really important and impactful. And I think that this investment is just going to make all of those efforts better. So, Madam Chair, that's it for me. I don't know if there is public testimony.
Yeah, I don't see anyone, but I'll double check. Carrie or Cora, do you guys see anyone who wants to testify? If so, they can raise their blue hand. So if there are folks who want to testify or provide public testimony, please raise a blue hand.
No, I don't have anyone.
Okay, thank you, Cora. You're the best.
You're welcome. You too.
Thank you. Central staff, what would we do without you guys?
I love you guys.
We do too. So I don't know if Sergeant or Jenna or Lauren, anyone have any final remarks before we wrap up? I know how busy you guys are, so I'll turn the floor over to you. Jenna?
I'll just say that this has been phenomenal for me. I've been working with this for 10 years, and this is truly just really gratifying to see this program coming to fruition. And many, many thanks to Councilor Sabi George, because you've been so instrumental in making this happen. So thank you.
Thank you. Dan, do you have something? I see you're unmuted.
I was just going to say thank you. Sorry, two people, one room. Going to say thank you again. And to follow up to the second question about the arrest, just if someone gets arrested doesn't mean the door is closed. There's still options after that for them to be diverted. And sometimes we need to arrest somebody in order to get them into treatment. For instance, there was a guy in Dorchester who had been Section 12 several times, but the civil commitment system was not even able to maintain his safety or their safety within the hospital setting, so it had to go into more of the forensic setting in Bridgewater. And unfortunately, charges had to be in place in order for that to have happened. But there are still other options after that to divert them out of that system, even prior to having incidents be put on their criminal history. They can have hearings and everything else set up. Thank you again, everybody, for being here, and Councilor George for setting this up, and Jenna and Lauren and Tasha and Melissa for all the work you did to get the numbers.
Thank you. Tasha or Lauren or Josh or Sergeant, anyone else? Tasha, do you want to say a few closing remarks?
Just a big thank you again for inviting us here today and giving us the opportunity to speak. I think, you know, both the BEST team as a whole and our partnership with the police has such an important role to play in really serving the members of our community, serving them where they would like to be served and serving them when they need to be served. And so any opportunity to expand that is really key from my perspective. So thank you again so much, Madam Chair, and thank you to Councilor Sabi George for inviting us here.
Thank you, Tasha. Lauren?
I just wanted to thank you as well, and I just wanted to share that I've spent my whole career at the intersection of the mental health system and the criminal justice system, and I think this kind of discussion provides an opportunity for us to figure out how to have these systems that are incongruent at times communicate well with each other. And I think we have some people calling 911 who may have been better served to call BEST. They really didn't need that response. We have some people calling the BEST 800 number where it's too emergent and is not safe to wait to have a clinician come on their own because of the timely factor or because they need an officer really to maintain the safety. So I really think that partnerships like this have the potential to have these systems interface in a way that is going to bring the right service to the individual at that time of need. And that really, as you mentioned, what John said he got in that encounter, I would like to think that, you know, that's the ideal for all of us, for all officers, for all clinicians, that we're trying to meet people's needs in a difficult moment. So I think through the support we get from the council and from partnerships like this, we can really do our best to right-size those interventions. And I really thank you for your support.
Thank you, Lauren. Sergeant, do you want to wrap us up? Do you want to say anything? Or Josh or Joshua? I see faces. So.
I just Dan and Lauren said it the best. Thank you for all involved. It was great being able to testify today to give you guys hopefully a thorough explanation as to the benefit of having a co-response in the BEST team with us. So thank you so much to everybody involved, especially City Councilor Sabi George, yourself, and my team, and Jenna and Lauren and Tasha putting us together. So thank you so much.
Thank you. Josh?
Yeah, I think I'd be remiss if I didn't say this. I've been a police officer for almost 20 years, and policing in my time has certainly changed. And when the sergeant asked me to be on this meeting, it wasn't anything he was ordering me to do. It was something I wanted to do because I want to be here to say that this does work. And if it didn't work, I wouldn't have been on this call. And so we see it every day. We see this stuff working every day. And people are surprised sometimes when they see the job that we're doing as police officers. But it's a non-traditional approach, and it's the future. So I just want to say thank you for listening to us today.
Thank you. Appreciate you. Councilor Mejia, do you want to wrap up? I went to Councilor, I didn't see you, so I went to Councilor Sabi George as a sponsor. But I'll wrap.
No, I just wanted to say thank you to everyone, Jenna, Peter, Josh, the whole squad, for sharing so much. Lauren, and everyone on the call today. I walked away learning a lot and actually leaving really hopeful for what is to come. Oftentimes we don't come into these spaces and leave with a sense of, oh, okay, this is good to hear and know and support, right? And Officer Josh, I also really do appreciate your service, and you are incredibly correct when you talk about what the future looks like. And I think that the more we can lead again with some heart and really with some compassion, I think that this is what the city needs in this moment in time. And I think that this approach really centers that in seeing people, seeing the human, right? So thank you for all that you do. It's greatly appreciated. I know I always come across as the little rebel rouser, but know that my heart is always in the right place, and I really do appreciate everyone and all your work and the service that you do for our city. And thank you, Councilor Sabi George, for your commitment to this particular issue and all that you do for those who are struggling with mental health and substance abuse and homelessness. I think that you have definitely carved a lane, and you drive that lane is like do not pass go. That's like your lane, and you are like leading in that space, and really grateful to be with you in this service. So thank you all. Thank you.
Thank you, Councilor Mejia. And again, thank you, Councilor Sabi George, for organizing the hearing, of course, working with central staff. Really informative, a lot of information that people needed to know in this particular time. So thank you. Of course, thank you to all of our employees from the administration for the work you guys do every day, including the panelists who had to jump a little early, and for the partners on the ground. And to those who provided public testimony and shared some of their stories, which is not easy to do in a space like this. So thank you so much. And again, thank you, Councilor Sabi George. Thank you, Central Staff, Carrie Cora. Thank you, guys. We're going to wrap this up, and everyone stay safe and healthy. Bye.
Bye. Thank you, everybody. Bye.